Bang Bangkit membangun negeri. Kota Malang menjadi kota pendidikan terbesar kedua di Jawa Timur. Tempat ragam budaya dan latar belakang masyarakat berinteraksi dengan harmonis. Sebagai pusat peradaban dari masa ke masa, Kota Malang terus berkembang menuju Smart City, mengembangkan sumber daya manusia yang unggul di segala bidang, termasuk kesehatan. Politeknik Kesehatan Kemenkes Malang, atau yang lebih dikenal dengan nama Poltekkes, membuka cakrawala dunia melalui ilmu pengetahuan di bidang kesehatan. Pendidikan tinggi vokasi kesehatan ini didirikan oleh Kementerian Kesehatan Republik Indonesia. Disinilah putra-putri bangsa dari berbagai penjuru Nusantara mengembangkan kompetensi dan membentuk karakter dalam membangun peradaban bangsa yang bermartabat.
Assalamualaikum warahmatullahi wabarakatuh. Saya Budi Susatya, selaku Direktur Politeknik Kesehatan Kemenkes Malang. Dalam rangka menghadapi era digital 4.0 dan masyarakat ekonomi ASEAN, Poltekkes Kemenkes Malang siap mencetak tenaga yang berkarakter dan unggul. Oleh karena itu, saya percaya langkah kecil yang saudara pilih akan menjadi penuntun ke arah yang lebih besar. Sekian, Assalamualaikum warahmatullahi wabarakatuh.
Poltekkes memulai kiprahnya sejak tahun 2001, lahir dari gabungan 7 akademi kedinasan kesehatan di wilayah Jawa Timur bagian selatan. Komitmen Poltekkes dalam melahirkan praktisi kesehatan yang andal dan kompeten tampak dalam visinya, yaitu menjadi institusi pendidikan tinggi vokasi kesehatan yang berkarakter dan unggul pada tahun 2019. Dengan penetapan sasaran yang strategis, dilaksanakan upaya pencapaian kinerja melalui indikator yang telah ditetapkan. Bersinergi dalam kerja kreatif, menjadikan Politeknik Kesehatan Kemenkes Malang sebagai salah satu barometer bagi perguruan tinggi kesehatan di Indonesia, yang dibuktikan melalui pencapaian kinerja dalam beberapa indikator penting. 17 tahun berdiri, Poltekkes telah berhasil memperoleh akreditasi B, terkualifikasi sebagai kualifikasi 1 Politeknik Kesehatan. Pencapaian tersebut merupakan gambaran dari penerapan sistem manajemen pembelajaran dan pemanfaatan teknologi informasi yang cukup pesat. Turut mewarnai pertumbuhan ilmu kesehatan, Poltekkes menyelenggarakan pendidikan, program studi diploma gizi, program studi diploma keperawatan, program studi diploma kebidanan, program studi diploma analis farmasi dan makanan, program studi diploma perekam medis dan informasi kesehatan, program studi diploma asuransi kesehatan, program studi diploma teknologi bank darah, dan program studi sarjana terapan promosi kesehatan, serta program studi pendidikan profesi, dietitian, nurse, dan bidan. Program studi tersebut tersebar dalam 7 kampus yang berlokasi di daerah Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, dan Ponorogo. Poltekkes memiliki 4.500 mahasiswa yang dipersiapkan melangkah mewujudkan cita-cita luhur. Untuk menghadirkan atmosfer yang mendukung perkuliahan, Poltekkes menyediakan fasilitas yang memadai, mulai dari ruang kuliah yang nyaman dengan media pembelajaran modern, laboratorium fungsional terintegrasi yang didukung teknologi canggih, perpustakaan terpadu dan berbasis online, unit bimbingan konseling, asrama, masjid kampus, gazebo, kantin, fasilitas olahraga, hotspot area, dan secure parking. Dirancang sebagai perguruan tinggi vokasi, Poltekkes telah mengukuhkan diri menjadi barometer perkembangan pembelajaran ilmu kesehatan di Indonesia. Disokong penerapan kurikulum pendidikan tinggi vokasi dengan persentase lebih dari 60% praktikum dan 40% teori yang akan mempertajam atau mengasah keterampilan mahasiswa dengan praktik di laboratorium dan wahana praktik. Poltekkes turut mengimplementasikan metode pengajaran yang inovatif, menyenangkan, dengan konsep enjoy learning, serta menerapkan internet-based test atau IBT dalam ujian dan pembelajaran dengan e-learning. Pendidikan berkualitas dibentuk dengan penanaman nilai-nilai yang dihadirkan melalui 220 tenaga pengajar dengan kualifikasi magister dan doktoral yang sudah tersertifikasi. Dengan berbagai disiplin ilmu serta sebagai teladan dalam kehidupan sehari-hari, Poltekkes turut menanamkan karakter dan etika kebangsaan serta unggul dalam keprofesian guna menghadapi masyarakat ekonomi ASEAN. Selain akademik, Poltekkes turut mempersiapkan mahasiswa yang percaya diri dengan kemampuannya melalui unit kegiatan mahasiswa. Mengembangkan minat bakat mahasiswa mulai dari bidang seni, olahraga, sains, bahasa, dan kerohanian. Disinilah langkah mewujudkan cita-cita dimulai dengan menyalurkan kebebasan berekspresi. Poltekkes mendidik mahasiswa agar setia kepada NKRI dan memiliki sikap mental berkarakter dengan pendidikan bela negara. Poltekkes semakin menunjukkan keberhasilan dalam mencetak bibit-bibit unggul dengan prestasi-prestasi yang diraih baik di tingkat nasional maupun internasional. Kerjasama dalam dan luar negeri, baik dengan institusi pendidikan kesehatan maupun institusi pelayanan kesehatan. Keberhasilan juga tampak terlihat dari sebaran dan peran alumni Poltekkes di instansi kesehatan hingga bertaraf internasional yang tersebar di kawasan Asia, Eropa, hingga Amerika dan Australia.
Good afternoon, Poltekkes. My name is Debbie Salvamoga and I'm International Student of Taipei Medical University. I'm very proud and grateful as a Poltekkes alumnus. I learned a lot of knowledge and valuable and memorable experiences when I was student at Poltekkes.
For medical record and health information student, keep spirit because our profession is very much needed and important.
My message to all alumni and my junior, you can do it. Thank you.
I'm proud to be an alumnus State Health Polytechnic Malang. Keep increase your working and good Poltekkes. Wassalamualaikum warahmatullahi wabarakatuh.
Politeknik Kesehatan Kemenkes Malang, the truly vocational education of health.
Bangkit membangun negeri. Kota Malang menjadi kota pendidikan terbesar kedua di Jawa Timur. Tempat ragam budaya dan latar belakang masyarakat berinteraksi dengan harmonis. Sebagai pusat peradaban dari masa ke masa, Kota Malang terus berkembang menuju Smart City. Mengembangkan sumber daya manusia yang unggul di segala bidang, termasuk kesehatan. Poltekkes Kesehatan Kemenkes Malang, atau yang lebih dikenal dengan nama Poltekkes, membuka cakrawala dunia melalui ilmu pengetahuan di bidang kesehatan. Pendidikan tinggi vokasi kesehatan ini didirikan oleh Kementerian Kesehatan Republik Indonesia. Disinilah putra-putri bangsa dari berbagai penjuru Nusantara mengembangkan kompetensi dan membentuk karakter dalam membangun peradaban bangsa yang bermartabat.
Assalamualaikum warahmatullahi wabarakatuh. Saya Budi Susatya, selaku Direktur Politeknik Kesehatan Kemenkes Malang. Dalam rangka menghadapi era digital 4.0 dan masyarakat ekonomi ASEAN, Poltekkes Kemenkes Malang siap mencetak tenaga yang berkarakter dan unggul. Oleh karena itu, saya percaya langkah kecil yang saudara pilih akan menjadi penuntun ke arah yang lebih besar. Sekian, wassalamualaikum warahmatullahi wabarakatuh.
Poltekkes memulai kiprahnya sejak tahun 2001, lahir dari gabungan 7 akademi kedinasan kesehatan di wilayah Jawa Timur bagian selatan. Komitmen Poltekkes dalam melahirkan praktisi kesehatan yang andal dan kompeten tampak dalam visinya, yaitu menjadi institusi pendidikan tinggi vokasi kesehatan yang berkarakter dan unggul pada tahun 2019. Dengan penetapan sasaran yang strategis, dilaksanakan upaya pencapaian kinerja melalui indikator yang telah ditetapkan. Bersinergi dalam kerja kreatif, menjadikan Politeknik Kesehatan Kemenkes Malang sebagai salah satu barometer bagi perguruan tinggi kesehatan di Indonesia yang dibuktikan melalui pencapaian kinerja dalam beberapa indikator penting. 17 tahun berdiri, Poltekkes telah berhasil memperoleh akreditasi B, terkualifikasi sebagai kualifikasi 1 Politeknik Kesehatan. Pencapaian tersebut merupakan gambaran dari penerapan sistem manajemen pembelajaran dan pemanfaatan teknologi informasi yang cukup pesat. Turut mewarnai pertumbuhan ilmu kesehatan, Poltekkes menyelenggarakan pendidikan, program studi diploma gizi, program studi diploma keperawatan, program studi diploma kebidanan, program studi diploma analis farmasi dan makanan, program studi diploma perekam medis dan informasi kesehatan, program studi diploma asuransi kesehatan, program studi diploma teknologi bank darah, dan program studi sarjana terapan promosi kesehatan, serta program studi pendidikan profesi, dietitian, nurse, dan bidan. Program studi tersebut tersebar dalam 7 kampus yang berlokasi di daerah Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, dan Ponorogo. Poltekkes memiliki 4.500 mahasiswa yang dipersiapkan melangkah mewujudkan cita-cita luhur. Untuk menghadirkan atmosfer yang mendukung perkuliahan, Poltekkes menyediakan fasilitas yang memadai, mulai dari ruang kuliah yang nyaman dengan media pembelajaran modern, laboratorium fungsional terintegrasi yang didukung teknologi canggih, perpustakaan terpadu dan berbasis online, unit bimbingan konseling, asrama, masjid kampus, gazebo, kantin, fasilitas olahraga, hotspot area, dan secure parking. Dirancang sebagai perguruan tinggi vokasi, Poltekkes telah mengukuhkan diri menjadi barometer perkembangan pembelajaran ilmu kesehatan di Indonesia. Disokong penerapan kurikulum pendidikan tinggi vokasi dengan persentase lebih dari 60% praktikum dan 40% teori yang akan mempertajam atau mengasah keterampilan mahasiswa dengan praktik di laboratorium dan wahana praktik. Poltekkes turut mengimplementasikan metode pengajaran yang inovatif, menyenangkan, dengan konsep enjoy learning, serta menerapkan internet-based test atau IBT dalam ujian dan pembelajaran dengan e-learning. Pendidikan berkualitas dibentuk dengan penanaman nilai-nilai yang dihadirkan melalui 220 tenaga pengajar dengan kualifikasi magister dan doktoral yang sudah tersertifikasi. Dengan berbagai disiplin ilmu serta sebagai teladan dalam kehidupan sehari-hari, Poltekkes turut menanamkan karakter dan etika kebangsaan, serta unggul dalam keprofesian guna menghadapi masyarakat ekonomi ASEAN. Selain akademik, Poltekkes turut mempersiapkan mahasiswa yang percaya diri dengan kemampuannya melalui unit kegiatan mahasiswa, mengembangkan minat bakat mahasiswa mulai dari bidang seni, olahraga, sains, bahasa, dan kerohanian. Disinilah langkah mewujudkan cita-cita dimulai dengan menyalurkan kebebasan berekspresi. Poltekkes mendidik mahasiswa agar setia kepada NKRI dan memiliki sikap mental berkarakter dengan pendidikan bela negara. Poltekkes semakin menunjukkan keberhasilan dalam mencetak bibit-bibit unggul dengan prestasi-prestasi yang diraih baik di tingkat nasional maupun internasional. Kerjasama dalam dan luar negeri, baik dengan institusi pendidikan kesehatan maupun institusi pelayanan kesehatan. Keberhasilan juga tampak terlihat dari sebaran dan peran alumni Poltekkes di instansi kesehatan hingga bertaraf internasional yang tersebar di kawasan Asia, Eropa, hingga Amerika dan Australia.
Good afternoon, Poltekkes. My name is Debbie Salvamoga and I'm the international student of Taipei Medical University. I'm very proud and grateful as a Poltekkes alumnus. I learned a lot of knowledge and valuable and memorable experiences when I was student at Poltekkes.
For medical record and health information student, keep spirit because our profession is very much needed and important.
My message to all alumni and my junior, you can do it. Thank you.
I am proud to be an alumnus State Health Polytechnic Malang. Keep increase your working and good progress. Wassalamualaikum warahmatullahi wabarakatuh.
Politeknik Kesehatan Kemenkes Malang. The truly vocational education of health.
Bangkit membangun negeri. Kota Malang menjadi kota pendidikan terbesar kedua di Jawa Timur. Tempat ragam budaya dan latar belakang masyarakat berinteraksi dengan harmonis. Sebagai pusat peradaban dari masa ke masa, Kota Malang terus berkembang menuju Smart City. Mengembangkan sumber daya manusia yang unggul di segala bidang, termasuk kesehatan. Poltekkes Kesehatan Kemenkes Malang, atau yang lebih dikenal dengan nama Poltekkes, membuka cakrawala dunia melalui ilmu pengetahuan di bidang kesehatan. Pendidikan tinggi vokasi kesehatan ini didirikan oleh Kementerian Kesehatan Republik Indonesia. Disinilah putra-putri bangsa dari berbagai penjuru Nusantara mengembangkan kompetensi dan membentuk karakter dalam membangun peradaban bangsa yang bermartabat.
Assalamualaikum warahmatullahi wabarakatuh. Saya Budi Susatya, selaku Direktur Politeknik Kesehatan Kemenkes Malang. Dalam rangka menghadapi era digital 4.0 dan masyarakat ekonomi ASEAN, Poltekkes Kemenkes Malang siap mencetak tenaga yang berkarakter dan unggul. Oleh karena itu, saya percaya langkah kecil yang saudara pilih akan menjadi penuntun ke arah yang lebih besar. Sekian, Assalamualaikum warahmatullahi wabarakatuh.
Polkesma memulai kiprahnya sejak tahun 2001, lahir dari gabungan 7 akademi kedinasan kesehatan di wilayah Jawa Timur bagian selatan. Komitmen Polkesma dalam melahirkan praktisi kesehatan yang andal dan kompeten tampak dalam visinya, yaitu menjadi institusi pendidikan tinggi vokasi kesehatan yang berkarakter dan unggul pada tahun 2019. Dengan penetapan sasaran yang strategis, dilaksanakan upaya pencapaian kinerja melalui indikator yang telah ditetapkan. Bersinergi dalam kerja kreatif, menjadikan Politeknik Kesehatan Kemenkes Malang sebagai salah satu barometer bagi perguruan tinggi kesehatan di Indonesia, yang dibuktikan melalui pencapaian kinerja dalam beberapa indikator penting. 17 tahun berdiri, Polkesma telah berhasil memperoleh akreditasi B, terkualifikasi sebagai kualifikasi 1 Politeknik Kesehatan. Pencapaian tersebut merupakan gambaran dari penerapan sistem manajemen pembelajaran dan pemanfaatan teknologi informasi yang cukup pesat. Turut mewarnai pertumbuhan ilmu kesehatan, Polkesma menyelenggarakan pendidikan, program studi diploma gizi, program studi diploma keperawatan, program studi diploma kebidanan, program studi diploma analis farmasi dan makanan, program studi diploma perekam medis dan informasi kesehatan, program studi diploma asuransi kesehatan, program studi diploma teknologi bank darah, dan program studi sarjana terapan promosi kesehatan, serta program studi pendidikan profesi, dietitian, nurse, dan bidan. Program studi tersebut tersebar dalam 7 kampus yang berlokasi di daerah Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, dan Ponorogo. Polkesma memiliki 4.500 mahasiswa yang dipersiapkan melangkah mewujudkan cita-cita luhur. Untuk menghadirkan atmosfer yang mendukung perkuliahan, Polkesma menyediakan fasilitas yang memadai, mulai dari ruang kuliah yang nyaman dengan media pembelajaran modern, laboratorium fungsional terintegrasi yang didukung teknologi canggih, perpustakaan terpadu dan berbasis online, unit bimbingan konseling, asrama, masjid kampus, gazebo, kantin, fasilitas olahraga, hotspot area, dan secure parking. Dirancang sebagai perguruan tinggi vokasi, Polkesma telah mengukuhkan diri menjadi barometer perkembangan pembelajaran ilmu kesehatan di Indonesia. Disokong penerapan kurikulum pendidikan tinggi vokasi dengan persentase lebih dari 60% praktikum dan 40% teori yang akan mempertajam atau mengasah keterampilan mahasiswa dengan praktik di laboratorium dan wahana praktik. Polkesma turut mengimplementasikan metode pengajaran yang inovatif, menyenangkan, dengan konsep enjoy learning, serta menerapkan Internet Based Test atau IBT dalam ujian dan pembelajaran dengan e-learning. Pendidikan berkualitas dibentuk dengan penanaman nilai-nilai yang dihadirkan melalui 220 tenaga pengajar dengan kualifikasi magister dan doktoral yang sudah tersertifikasi. Dengan berbagai disiplin ilmu serta sebagai teladan dalam kehidupan sehari-hari, Poltekkes turut menanamkan karakter dan etika kebangsaan serta unggul dalam keprofesian guna menghadapi masyarakat ekonomi ASEAN. Selain akademik, Poltekkes turut mempersiapkan mahasiswa yang percaya diri dengan kemampuannya melalui unit kegiatan mahasiswa. Mengembangkan minat bakat mahasiswa mulai dari bidang seni, olahraga, sains, bahasa, dan kerohanian. Disinilah langkah mewujudkan cita-cita dimulai dengan menyalurkan kebebasan berekspresi. Poltekkes mendidik mahasiswa agar setia kepada NKRI dan memiliki sikap mental berkarakter dengan pendidikan bela negara. Poltekkes semakin menunjukkan keberhasilan dalam mencetak bibit-bibit unggul dengan prestasi-prestasi yang diraih baik di tingkat nasional maupun internasional. Kerjasama dalam dan luar negeri, baik dengan institusi pendidikan kesehatan maupun institusi pelayanan kesehatan. Keberhasilan juga tampak terlihat dari sebaran dan peran alumni Poltekkes di instansi kesehatan hingga bertaraf internasional yang tersebar di kawasan Asia, Eropa, hingga Amerika dan Australia.
Good afternoon, Poltekkes. My name is Debbie Salvamoga and I'm the international student of Taipei Medical University. I'm very proud and grateful as a Poltekkes alumnus. I learned a lot of knowledge and valuable and memorable experiences when I was student at Poltekkes.
For medical record and health information student, keep spirit because our profession is very much needed and important.
My message to all alumni and my junior, you can do it. Thank you.
I am proud to be an alumnus State Health Polytechnic Malang. Keep increase your working and good focus. Wassalamualaikum warahmatullahi wabarakatuh.
Politeknik Kesehatan Kemenkes Malang, the truly vocational education of health.
Bangkit membangun negeri. Kota Malang menjadi kota pendidikan terbesar kedua di Jawa Timur. Tempat ragam budaya dan latar belakang masyarakat berinteraksi dengan harmonis. Sebagai pusat peradaban dari masa ke masa, Kota Malang terus berkembang menuju Smart City. Mengembangkan sumber daya manusia yang unggul di segala bidang, termasuk kesehatan. Poltekkes Kesehatan Kemenkes Malang, atau yang lebih dikenal dengan nama Poltekkes, membuka cakrawala dunia melalui ilmu pengetahuan di bidang kesehatan. Pendidikan tinggi vokasi kesehatan ini didirikan oleh Kementerian Kesehatan Republik Indonesia. Disinilah putra-putri bangsa dari berbagai penjuru Nusantara mengembangkan kompetensi dan membentuk karakter dalam membangun peradaban bangsa yang bermartabat.
Assalamualaikum warahmatullahi wabarakatuh. Saya Budi Susatya, selaku Direktur Politeknik Kesehatan Kemenkes Malang. Dalam rangka menghadapi era digital 4.0 dan masyarakat ekonomi ASEAN, Poltekkes Kemenkes Malang siap mencetak tenaga yang berkarakter dan unggul. Oleh karena itu, saya percaya langkah kecil yang saudara pilih akan menjadi penuntun ke arah yang lebih besar. Sekian, wassalamualaikum warahmatullahi wabarakatuh.
Polkesma memulai kiprahnya sejak tahun 2001, lahir dari gabungan 7 akademi kedinasan kesehatan di wilayah Jawa Timur bagian selatan. Komitmen Polkesma dalam melahirkan praktisi kesehatan yang andal dan kompeten tampak dalam visinya, yaitu menjadi institusi pendidikan tinggi vokasi kesehatan yang berkarakter dan unggul pada tahun 2019. Dengan penetapan sasaran yang strategis, dilaksanakan upaya pencapaian kinerja melalui indikator yang telah ditetapkan. Bersinergi dalam kerja kreatif, menjadikan Politeknik Kesehatan Kemenkes Malang sebagai salah satu barometer bagi perguruan tinggi kesehatan di Indonesia, yang dibuktikan melalui pencapaian kinerja dalam beberapa indikator penting. 17 tahun berdiri, Polkesma telah berhasil memperoleh akreditasi B, terkualifikasi sebagai kualifikasi 1 Politeknik Kesehatan. Pencapaian tersebut merupakan gambaran dari penerapan sistem manajemen pembelajaran dan pemanfaatan teknologi informasi yang cukup pesat. Turut mewarnai pertumbuhan ilmu kesehatan, Polkesma menyelenggarakan pendidikan, program studi diploma gizi, program studi diploma keperawatan, program studi diploma kebidanan, program studi diploma analis farmasi dan makanan, program studi diploma perekam medis dan informasi kesehatan, program studi diploma asuransi kesehatan, program studi diploma teknologi bank darah, dan program studi sarjana terapan promosi kesehatan, serta program studi pendidikan profesi, dietitian, nurse, dan bidan. Program studi tersebut tersebar dalam 7 kampus yang berlokasi di daerah Malang, Jember, Lawang, Blitar, Kediri, Trenggalek, dan Ponorogo. Polkesma memiliki 4.500 mahasiswa yang dipersiapkan melangkah mewujudkan cita-cita luhur. Untuk menghadirkan atmosfer yang mendukung perkuliahan, Polkesma menyediakan fasilitas yang memadai, mulai dari ruang kuliah yang nyaman dengan media pembelajaran modern, laboratorium fungsional terintegrasi yang didukung teknologi canggih, perpustakaan terpadu dan berbasis online, unit bimbingan konseling, asrama, masjid kampus, gazebo, kantin, fasilitas olahraga, hotspot area, dan secure parking. Dirancang sebagai perguruan tinggi vokasi, Polkesma telah mengukuhkan diri menjadi barometer perkembangan pembelajaran ilmu kesehatan di Indonesia. Disokong penerapan kurikulum pendidikan tinggi vokasi dengan persentase lebih dari 60% praktikum dan 40% teori yang akan mempertajam atau mengasah keterampilan mahasiswa dengan praktik di laboratorium dan wahana praktik. Polkesma turut mengimplementasikan metode pengajaran yang inovatif, menyenangkan, dengan konsep enjoy learning, serta menerapkan Internet-Based Test atau IBT dalam ujian dan pembelajaran dengan e-learning. Pendidikan berkualitas dibentuk dengan penanaman nilai-nilai yang dihadirkan melalui 220 tenaga pengajar dengan kualifikasi magister dan doktoral yang sudah tersertifikasi. Dengan berbagai disiplin ilmu serta sebagai teladan dalam kehidupan sehari-hari,
Attention please, Kuliah Tamu will begin. Assalamualaikum warahmatullahi wabarakatuh. Good morning, best wishes for all of us. Om Swastiastu, Namo Buddhaya, Salam Kebajikan. The Honorable Director of Politeknik Kesehatan Kemenkes Malang, Mr. Budi Susatya SKP Menkes. Head of Midwifery Department, Politeknik Kesehatan Kemenkes Malang, Mrs. Herawati Mansur, SST MPD MPC. Head of Studies Program in Midwifery Field Poltekkes Kemenkes Malang. First speaker, Mrs. Mariamah Masalamani, MSc, Midwifery Lecturer at Masa University, Malaysia. Second speaker, Mrs. Maria Geli Jordan, PhD NSc, Women Empowerment and Public Health Lecturer at Science Power University, Philippines. Third speaker, Mrs. Fili Imaniar, SPD, from Yayasan Putra Pancasila, and all invited guests as well as participants. Welcome to Malang, and welcome to Kuliah Tamu, Midwifery of Malang, Politeknik Kesehatan Kemenkes Malang, 25th of September 2020. First of all, let us say thanks to Allah Subhanahu wa Ta'ala, who has been giving us mercy, guidance, happiness, and health, so we can attend and participate in this event Kuliah Tamu today without any obstacles until now. Praise and salutation be upon to our Prophet Muhammad Sallallahu Alaihi Wasallam, the last messenger, the best figure of this universe. The person who was able to save us from the Jahiliyyah era to the lightning era. Let me introduce myself. My name is Sadinta Jasmine, as I MC for the event Kuliah Tamu today with a topic about strategy to improve maternal and child health by enhancing equal rights for women. On this special morning, we have several agendas. So, let me to read several sequences of our agenda are: first, opening; second, pray together; third, singing Indonesia National Anthem Indonesia Raya and the hymn of Polytechnic Health Ministry of Health Malang; fourth, head of event report; fifth, speech by the Director of the Health Polytechnic of the Ministry of Health of Malang; sixth, material presentation by Mrs. Maria Masalah Money MSc and Q&A session. 7. Material presentation by Mrs. Maria Girly Jordan, PhD NSc and Q&A session. 8. Material presentation by Mrs. Feli Immanuel and Q&A session. 9. Closing speech by the head of the midwifery department. 10. Photo group. And the last, closing. That's all our agendas for today. Before we get started, let us pray together with each belief. Prayer begins. May God let this event run very well. Amen. Therefore, I will read the following rules and regulations for Kuliah Tamu participants to keep the event conducive. A. First thing first, let me know your name and your origin institution. So, you are requested to rename your username with the following format: name, _ origin of study program. B. You have to turn your camera on so that Mrs. Mariamah, Mrs. Maria, and Mrs. Fili could see your beauty. C. Turn off your microphone to avoid any disturbance. D. The presence link will be shared to the chat box every 10 minutes from 8 o'clock until 9 o'clock AM. You only need to fill it once. E. The evaluation link will be shared to the Zoom meeting chat room after the discussion session ends. And make sure to give correct answer of your identity. F. Please listen to the material mindfully to absorb all this knowledge. G. Feel free to ask questions. H. The material can be downloaded after the material delivery session via the link that will be shared via the chat box. I. Last but not least, there was a group photo session at the end of the event, so prepare your sweetest smile. The next event was singing the Indonesian national anthem, Indonesia Raya, and the hymn of Poltekkes Kesehatan Kemenkes Malang. All participants are asked to stand up straight. Good for all participants. Please sit back. Now, we will hear the Chief Executive Report, which will be submitted by my sister, Indian Tirani Rahma, to those in charge.
Assalamualaikum warahmatullahi wabarakatuh. Good morning and peace to all of us. The Honorable the Director of Health Polytechnic of Malang, Mr. Budi Susatya, Kemenkes, the Honorable Head of Department of Midwifery, Health Polytechnic Ministry of Health Malang, Ms. Herawati Mansur, SST MPD MPSI, the Honorable Head of the Midwife Professional Study Program of Malang, Midwifery Applied Bachelor Study Program of Malang, Jember, and Kediri, Head of Diploma 3 Midwifery Study Program of Malang, and all of lecture and education staff from Department of Midwifery, Health Polytechnic Ministry of Health Malang, and the Honorable Guest Lecturer from University of Mahsa, Malaysia, Ms. Maria Mahmasalamani, MSc, the Honorable Guest Lecturer from St. Paul University, Philippines, Ms. Maria Magirli Dulin Jordan, PhD and SC, MSN, RN, the Honorable Guest Lecturer from Putra Pancasila Foundation, Ms. Firly Imaniar, SPD, and the Honorable all participants and also all the committee friends that I'm proud of. Alhamdulillah, we pray to the presence of Allah Subhanahu wa Ta'ala, the one Almighty God, for His pleasure, so that we can all take part in Guest lecture in good health without missing anything. Amin. On this occasion, allow us as the organizing committee to report this activity as follows. First, implementation basis of this activity are Diploma 3 Study Program Students Association Applied Bachelor and Professional Education of Midwives, Health Polytechnic Ministry of Health Malang in 2021. Number of committee who participate in this activity amount to 21 committee from HMP, and number of participants who attend this activity are 450 from lecture and education staff, totaling 28 people. As for the purpose of holding a guest lecture, which is to add insight to students of the Malang Midwifery Department of Health Polytechnic of the Ministry of Health Malang regarding to relationship of gender equality to maternal and child health. That's the report I can deliver. Me, as the chairman of the guest lecture activities, would like to thank all of the participants involved. So, inshallah, the event will go well, and on this occasion, we would like to express our deepest and apologies if there are deficiencies in the implementation of activities. That's all I can say. Wassalamualaikum warahmatullahi wabarakatuh.
Many thanks to Indian Tirani Rahma for reporting. The next agenda is speeches by Mr. Budi Susatya, SKP Kemenkes, as Director Politeknik Kesehatan Kemenkes Malang. For Mr. Budi Susatya, SKP Kemenkes, please, time is yours.
Okay, thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. I'm sorry, I will speak in Indonesian. Yang kami hormati narasumber atau speaker experts from Masa University, Malaysia, Miss Masalama, and Miss Maria Dirli ya, from SPUP Filipina. Yang kami hormati juga Ketua Jurusan Kebidanan Ibu RT Mansur, yang kami juga Ketua Unit Hubungan Internasional Bapak Isabari PhD, dan para Kaprodi, Sekjur di lingkungan jurusan Kebidanan, dan para mahasiswa peserta kegiatan kuliah tamu yang berbahagia, yang baik yang ada di Malang maupun yang ada di Banjarmasin dan juga di Metro Lampung. Alhamdulillah, puji syukur kepada Allah SWT atas limpah rahmatnya, kita masih diberikan nikmat sehat dan juga nikmat sempat, sehingga pagi ini kita bisa bersama-sama mengikuti kegiatan kuliah tamu yang diselenggarakan oleh mahasiswa jurusan Kebidanan dengan mendatangkan narasumber. Pemohon maaf yang belum kami sebut tadi, narasumber dari Yayasan Pancasila ya, Yayasan Putra Pancasila, yaitu Ibu Firly Imaniar SPD. Ya mohon maaf terlewat. Dengan kegiatan ini mudah-mudahan kuliah tamu nanti ini akan memberikan suatu manfaat, terutama penambahan wawasan dan juga pencerahan terkait dengan ilmu di kebidanan. Memang saat ini ilmu kebidanan di Indonesia terus berkembang dan tumbuh seiring dengan tuntutan dari masyarakat, sehingga skill, knowledge ini juga betul-betul dituntut oleh para mahasiswa yang nantinya setelah lulus akan terjun di dalam memberikan suatu layanan asuhan kebidanan di masyarakat. Tentu dengan adanya penyesuaian dan juga tuntutan dari masyarakat, maka profesi bidan ini juga harus bisa menyesuaikan diri terhadap tuntutan dari masyarakat, terutama dengan perkembangan situasi penyakit, alat-alat yang kesehatan yang semakin lebih maju dibandingkan dari dunia akademik, maka ini barangkali tentu ada suatu pendekatan-pendekatan yang lebih baik. Saya ucapkan terima kasih kepada narasumber, baik yang berasal dari SPUP, dari Masa University, dan juga dari Yayasan Putra Pancasila, yang telah berkenan untuk bisa memberikan suatu pencerahan kepada para mahasiswa dan juga para dosen di lingkungan jurusan kebidanan di sela-sela waktu yang weekend ini, hari Sabtu, dari hari libur, tetapi narasumber kita masih berkenan untuk memberikan suatu masukan kepada kita semua. Mudah-mudahan dengan masukan tadi itu akan memberikan suatu manfaat dan menjadi suatu amalan baik dari narasumber kita. Saya ucapkan terima kasih kepada Ketua Jurusan, ya, Sekjur dan Kaprodi, serta juga para mahasiswa yang telah menginisiasi kegiatan ini, dan juga lebih khusus juga Pak Gisa yang telah memberikan satu jalur atau jalan untuk memberikan narasumber. Dan saya berharap kegiatan ini tidak berhenti di sini, terus bisa berlangsung, baik itu nanti dalam bentuk-bentuk kegiatan ilmiah yang lain, misalnya dari penelitian ataupun juga pengajian masyarakat, dan syukur-syukur nanti bisa ada semacam kunjungan dari mahasiswa Indonesia ataupun Malaysia saling bergiliran, sehingga nanti para mahasiswa juga memahami dan tahu situasi dan kondisi di negara tetangga, bagaimana sebetulnya kemajuan dari layanan atau asuhan kebidanan di Malaysia ataupun juga di Filipina. Nah, oleh karena itu mungkin mahasiswa juga harus siap-siap kalau seandainya mau, mungkin Bu Kajur, mungkin bisa didata, tapi dengan biaya sendiri loh ya. Biaya sendiri, nanti sambil ke sana, mungkin bisa di-setting, coba nanti bisa menabung, sehingga ada semacam pertukaran mahasiswa. Karena ini pertukaran mahasiswa menjadi suatu tuntutan dengan adanya revitalisasi pendidikan di Politeknik. Jadi salah satunya adalah pertukaran mahasiswa ke luar negeri. Sehingga dengan demikian, dalam Merdeka Belajar Kampus Merdeka itu, salah satu kegiatannya adalah di samping tukar pelajar mahasiswa juga magang dan juga penelitian yang terkait dengan hilirisasi nanti ini juga harus bisa dilakukan. Saya yakin kalau mahasiswa mau dan insya Allah itu semua akan bisa berjalan nanti, walaupun tidak semuanya, tetapi ya siapa yang berkehendak atau siapa yang nanti mau untuk bisa mengunjungi ke sana Malaysia ataupun di Filipina SPUP, karena kita juga pernah kedatangan mahasiswa dari SPUP dalam acara Mercy apa waktu itu ya, saya lupa, itu kurang lebih sekitar sepekan atau 10 hari lah di Malang. Nah, nanti itu mungkin bisa saling bergantian antara mahasiswa kita dengan mahasiswa yang ada di Malaysia ataupun di Filipina. Saya kira itu yang bisa kami sampaikan. Dengan ucap bismillahirrahmanirrahim, maka kuliah tamu pagi ini yang diselenggarakan oleh jurusan Kebidanan, dengan ini saya akan dimulai. Sekian. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much to Mr. Budi Satya, SKP Kemenkes, for giving a speech. Next, let's check the midwifery study program out on our profile video. Participants, please kindly turn your camera on and mute your microphone. Also, don't forget to fill the presence form to prove your attendance, but no need to fill it twice. And finally, here's the main agenda that we're all waiting for. Material presentation with the health promotion strategy for pregnancy woman and child, which will be led by Wija Sista Aprilia Firdaus as moderator. Before we get into the discussion, let's get to know Wija Sista Aprilia Firdaus. Wija Sista Aprilia Firdaus. She's a student of midwife profession education at Poltekkes Kesehatan Kemenkes Malang. No wonder she's incredibly awesome as the third winner of National Health Polytechnic English Debate Competition in 2018 representing Poltekkes. Besides, she was quite active on seminar participation on the newest one in medication or midwifery case discussion in 2021. For Dwija Sista Aprilia Firdaus, please, time is yours.
All right, thank you, Ms. Radinta Jasmine, as the Master of Ceremony. I will take the agenda from now on. Good morning, everyone. A warm welcome to all. Thank you for finding time and joining today's guest lecture. My name is Dwija Sista Aprilia Firdaus, and I am a midwife profession education student in State Health Polytechnic of Malang. It's a very wonderful day, and I feel very privileged to extend my warm welcome to all presented here, especially to Bapak Budi Susatya as our Director of State Health Polytechnic of Malang, Head of Midwifery Department, Ibu Herawati Mansur, and three of our special speakers today, Mem Mariamah Masalamani, Mem Jerly Jordan, and Mrs. Firly Imaniar. Welcome everyone to today's lecture, along with the theme, Strategy to Improve Maternal and Child Health by Ensuring Equal Rights of Women. Just a little housekeeping before we get started. I will read the instruction for the audience during the presentation. The first, if the audience have any question during the presentation, please type them in the chat box below. We will have 15 minutes to discuss it after the end of the presentation or I will bring them up during the presentation if necessary. And for all the audiences, please mute yourself to keep the quality of sound function during the meeting. And then I may also mute the room if necessary, but please remember to unmute when you wish to share. Now, without further ado, I will introduce our first speaker for the day, Ms. Mariamah Masalamani. But first, I will read the curriculum vitae. Ms. Mariamah Masalamani was born on 6 February in 1959. Maybe Panitia can share the curriculum vitae. Okay, thank you. Is the curriculum vitae already visible on your screen? Ms. Radinta, is the curriculum vitae already visible on the screen? All right, maybe we can share the curriculum vitae once again. All right, here it is, our first speaker for the day, Ms. Mariamah Masalamani. Ms. Mariamah Masalamani was born on 6 February 1959 and place of residence in Johor Bahru, Malaysia. And ethnicity is Indian and her religion is Hindu. Her current employment are adjunct lecturer of midwifery at Mahsa University, Malaysia, and adjunct lecturer of midwifery at Monash University, Johor Bahru, Malaysia. And her profession is nursing. She also has a subspecialization in midwifery, and she has 37 years of working experience with Ministry of Health Malaysia, and also 3 years experience with Mahsa University and Monash University, Malaysia. And she also worked at Hospital Sultanah Aminah Johor Bahru, Malaysia. She has professional membership in Nursing and Midwifery Board Malaysia, Malaysian Nurse Association, and Malaysian Nurse Union. Her academic qualification, Ms. Mariamah Masalamani graduated from University of Northumbria, Newcastle upon Tyne, England, United Kingdom, for her Master and Bachelor Science in Nursing Practice Development, and Diploma in Higher Education for the Healthcare Professional at the same university. Also Diploma in Nursing in 1979 at Ministry of Health Malaysia. Ms. Mariamah also took the certification in post-basic midwifery, in post-basic management, and certificate in midwifery specialist course. And the next, okay. And here it is, we can see here that Ms. Mariamah also took part in a lot of national paper presentations and got plenty of achievements. The latest achievement that she got is in 2008, which is Anugerah Sijil Perakuan Akreditasi bagi program diploma lanjutan Kebidanan. That's all for the curriculum vitae for our first speaker, Ms. Mariamah Masalamani. Ms. Mariamah Masalamani, how are you today? Ma'am, good morning, ma'am.
Good morning.
How are you today, ma'am?
Yeah, I'm fine.
All right, that's nice. I'm glad to hear it, ma'am. Shall we start the presentation?
Am I the first speaker?
Yeah, of course you are.
Ah, I thought I am the second one. Okay.
All right, shall we start the presentation, ma'am?
Yeah, I will share my screen.
All right. And for your information, you have 45 minutes to deliver your presentation.
Okay.
All
Thank
right.
you.
All right. Now time is yours.
Why am I the host disabled participant screen sharing? I will share my PowerPoint. So wait for a while. I'm just uploading my PowerPoint.
All right, ma'am. All right.
Yeah, well, I thought I'll start at 10 o'clock here, said Dr. Kisa, but it's still 9:40 in our time. So you are earlier.
Yes, ma'am.
Yeah.
Sorry.
It's good I opened now. I don't know
Yeah,
if.
I will put it first.
Yeah. I cannot share my PowerPoint. I don't know why.
We're so sorry, ma'am. Maybe because our friends shared take the screen, so you cannot share the PowerPoint. But now you can, ma'am.
So can I share now?
Yeah, ma'am. You can. Time is yours. Thank you.
Thank you. Share my PowerPoint.
Excuse me, ma'am.
Yeah, I
We're
cannot
so
share
sorry.
it. Oh,
We're so
yes.
sorry, ma'am. The first speaker for today agenda is Ma'am Maria Mahmasalamani, and
Yeah.
you are the second speaker, ma'am.
Yeah, okay. So I will wait for the. So I'll finish first the first one. Okay.
All right. All right.
Okay. Okay.
Hello, good morning, everybody.
Good morning, ma'am.
Yeah. Good morning, ma'am.
The committee, please. Maybe you can pin out Miss Ma'am Mariama on the screen so we can also see her. All right. Thank you.
Only need two of them. Are we going to start?
Yes, ma'am. Yes, ma'am. You can. You are the first speaker for today's agenda, ma'am.
Oh, okay, so I can start, huh?
All right. Time is yours, ma'am.
All right. Who are the participants here? The lecturers? Who are the rest? Is Dr. Kisa here?
Salami.
Yeah.
Hey.
Yeah. Hi, Dr. Kisa.
Sorry.
Good morning. Good morning.
Our class sub area.
Oh, all right. All right. Okay, Dr. Kisa. So.
Thank you for joining.
Yeah. Thank you very much. So I'll give the talk now. Who are the rest here? The doctors? Someone who are the rest here? Students, huh? The participant.
Yes.
Okay. We will start. Thank you. Good morning and thank you to the moderator. Special thanks to Dr. Kisa Bahari for having invited me via Masa University as I'm an adjunct lecturer there also. And I'm also mainly working at Monash University as a full-time lecturer. Thank you for inviting me for this talk. It's very important. And thank you to the moderator. What's your name? Vija, is it? Okay, Vija, nice to see you. And all the participants. Okay, despite the COVID, so our session still goes on. Okay, same thing in Malaysia lah. We have to move on. Okay, welcome to my talk today. So we'll start off with the talk lah. Okay, all the questions can be put in the chat box or you can question me at the end of the session. Okay, so we'll start lah. Thank you.
Excuse me, ma'am. For your information, you have 45 minutes to deliver your presentation.
All right. Okay, so now it starts with the 45 minutes. Okay, no problem. I'll try to make it short, brief, precise, sweet. Okay. Today's topic we are going to discuss on health promotion strategy for pregnant women and children in Malaysia. Okay. Okay, the highlights for today would be a brief information on Malaysia and the healthcare system, followed by health promotion strategy in pregnant women and also in children, the norms of promoting health in pregnant women and children in Malaysia, and last but not least, we are going to discuss on the issues, challenges, and opportunities in promoting health in the pregnant women and children during COVID-19 pandemic in Malaysia. All right. Can I be heard clearly? Vija, can you hear me?
Yes, ma'am.
Okay, good. Okay. So Malaysia is a beautiful country, multiracial country. And our population is escalating escalating. If you see from 2010 until 2020, we have got 33 million population. We are proud of it lah. We are expecting more because we can accommodate. Okay. All right. This is the current population estimation in Malaysia in 2020. It is 2020 was 32.7. Now it is 33 million. We are proud of it lah. We are escalating. All right. As for the life expectancy of at birth in Malaysia in 2020, the female lived longer than the male lah. There are various reasons for that. So female lived to 77.6 years of age, and male lived 72.6 years of age. Okay, this male problem is actually due to NCDs, road traffic accident, and other things lah. Okay, otherwise they would have exceeded us. Okay, as for the percentage of citizen population by ethnic group, okay, the Bumiputra are the most, covering about 69.6%, followed by the Chinese, 22.6%, Indian, 6.8%, and the others is 1% lah. Okay, and our current Prime Minister is Dato' Seri Ismail Sabri Yaakob. I purposely want to put this here because most of you will be confused because too many PM came along the way lah. Okay, and our head minister is Dato' Hairi Jamaluddin Abu Bakar. Okay, he's a very promising man lah. Looks like he's very objective oriented. Looks like he started off with good governance lah, looking into pregnant women vaccination, childhood vaccination, and many other things. Okay, our laws governing the nursing in Malaysia is the Nurses Act, Midwives Act, Dangerous Drug Act, Medical Act, Prevention and Control of Infectious Disease Act, Birth and Death Registration Act, Human Tissue Act, Occupational Safety and Health Act, Private Healthcare and Facility Act, Children Act, and many, many more. So we have got to abide, all the nurses, our medical doctors, nurses, paramedics have to abide to all these rules and regulations. Okay, our healthcare objective actually is to improve healthcare status and promote social well-being. We also ensure equity and access to health and healthcare. So we also ensure efficiency in the use of resources. We enhance clinical effectiveness. We want to improve quality of service and patient satisfaction. And we want to ensure sustainability is always there despite the COVID-19 pandemic. Okay, what are the maternal health care services in Malaysia? Okay, we know that every woman has the right to expect her baby, okay, to be born alive and healthy, just as every other baby has the right to a living and healthy mother. So it's very important, like this is our mantra, you know, so we keep to this lah. Okay, introduction. Malaysia is actually upper income country with excellent healthcare service and good health status lah. The 11th Malaysia Plan 2016-2020, okay, articulates the development of goals, and health was the key component. So we had the tagline to improve health and well-being for all her nation lah. And our report card is very good. Okay, we achieve we reduce the maternal mortality rate and child mortality rate, just like the high income country group, high income countries. The country also has demonstrated success in reducing many communicable diseases such as malaria, HIV, childhood diseases. Okay, despite these successes, a few diseases as tuberculosis remain stubbornly persistent. Dengue was another one, and now currently COVID. We are fighting with COVID now. Okay, anyway, something looks promising because you know why our rates are reducing lah from 20, then 18, 17, 16, 15, 14. Hopefully, it will diminish after some time with the good conduct of our nation and also the vaccination program. Okay, the clinical governance of maternal and child health care. So it is actually defined as the framework through which healthcare organizations are accountable for continuously improving the quality of the service and also safeguarding the high quality care. So some of the initiative that has been adopted by Malaysia is a Safe Motherhood Initiative, which has got 6 pillars. It's all about family planning, services, antenatal care, obstetric care, postnatal care, abortion care, and STD and HIV control. So we communicate with the communication for behavior change, and then we provide primary health care and then equity for women. Other than that, the initiative that we adopted is the Millennium Development Goal. It has ended, but it is continued with the Sustainable Development Goal, SDG. Okay, this was we primarily looked into reduce promote gender equality 3, promote gender equality and empower women, reduce child mortality and improve maternal health. So we emphasize on this lah. Anyway, we succeeded. So when it ended, our report card was good about this MDG. All right, and then we continue with the SDG. So SDG now, we are looking into good health and well-being and quality education for the children at school. So especially this during this pandemic, these two areas are being emphasized. Though COVID may be there, though the pandemic is there, but system has been modified, and the quality of care is at all time is highly looked into. We give quality care to the pregnant mother and also to the children, and then gender equality. All right, see, this third agenda is good health and well-being. So we ensure healthy lives and promote well-being for all at all ages. So we follow the concept of from womb to the tomb. Right, from mother having conceived until the last day of their life lah. Okay, so this is a pictorial version of it. Okay. All right, Malaysia's health achievement and challenge. Okay, the mortality rate, as I told you, has declined lah, 21.2. It is similar to Western countries. So 21.2, 100,000 live births in 2020. So our challenge is to reduce further through quality maternal and child health management strategies lah. So we got a lot of strategies. Okay, our disease burden is NCD, so it has it is affecting Malaysians so much lah. Okay, with hypertension, hyperlipidemia, diabetes, overweight, obesity, tobacco use, and physical inactivity. Hello. Okay. Okay, and then the maternal health problems are also increasingly prevalent. Okay, a lot of environmental health issues is an ongoing challenge, and then managing the COVID-19 is another big challenge for us. Okay, brief info on maternal death in Malaysia. Okay, as we said that it has reduced lah. In 2019, 2020, it is 21.1 lah, just like the developed countries. Okay, this is another pictorial version. Okay, this is another pie chart showing that, okay, the young ones, 15 to 19 years is either the aged ones, 40 to 44, is higher, 73.7% MMR, and among the young or among the aged ones, okay, young ones 35.4% lah. Okay, so we are looking very seriously into this matter, especially with teenage pregnancies and care for teenage pregnancy, and also for the aged mothers lah, on what's that specific and frequent care for them, special care. Okay, as for the ethnicity, you see the others has got the highest number, 64.4%, followed by Indian, and then the Bumiputra and the Chinese. Okay, the MMR. Okay, this is a pie chart showing the death happened mostly during the postnatal period, that is 56.3%, followed by antenatal, and then intrapartum, and then post-abortion. Okay, a lot of maternal mortality happened in the married woman, 93.2%, and the non-married is 6.8% lah. Okay, and then maternal death by family planning practice, non-users, okay, had more death, 67%. Ever use is 21.4%. Partly used and no information or not used at all is 11.6%. All right, aim of maternity care and child care in Malaysia. Okay, we learn a lesson lah. Okay, by introducing this confidential inquiry into maternal death. So we use the CEMD, what's that, inquiry system or investigation system, okay, to improve our system of provision of maternal health care, maternal and child health care to reduce the MMR. Here, when we investigate the case, we don't want to see who has done it, but we don't punish them. We want to know what has happened, why it has happened, and how we could improve the system to bring about changes for quality care and to reduce the maternal and maternal mortality rate. Okay, factors contributing to reduction in MMR was, okay, it started lah with the socio-economic development. Okay, so more money, better service, and specific effort with the initiation of CEMD to reduce maternal mortality rate. Okay, very brief. Okay, early in the 50s, 1950s, we had 500 death over 100,000 live birth, but now you see only 21.1. So it'll be further reducing lah with a good system. So funding was good. And then another thing is one of the key factor that improved the MMR is improve the maternal mortality rate. We reduce the maternal mortality rate is empowering the midwife. Okay, we started the midwife ordinance in 1954, and we had revision, and Malaysia empowered the midwife. So if you see in our Malaysian context, 95% of the delivery is conducted by the midwife, the normal one. The doctors are all there, and they are so good. They empower the midwife. They are there, but they only do the supervision, help in a problematic case, and they lead the labor room or clinics, but they empower us to deliver the babies. So we are very fortunate to be a midwife in Malaysia. So I would say, I would salute them, hands up to them for having believed us. Okay, empowering of midwives, not only in the hospital, but also in the community setting. They are very important people, no? Not only in the delivery of babies, care during pregnancy, labor, puerperium, family planning. Okay, they are the great angels lah. Okay, so this empowering of midwife, okay, reduce the CEMD, reduce the maternal mortality rate through the CEMD activities lah. So next was the color coding system was introduced in Malaysia. So the color coding would be done by the midwives at the clinic, community clinic. So this color coding is very important to determine the level of a care for the mother. Okay, normal cases, okay, they are cared by the midwife. If they've got problem, then they'll be referred to the doctors. From the clinic, they'll be referred to the hospital, to the specialist, okay. And the midwives were empowered not only to take the antenatal card, but they were also given the power to do a referral letter. For example, it's an abnormal case, okay, abnormal pregnant case, okay, they are given the autonomy, the empowerment to do a referral letter, they refer to the hospital. And there's no question, straight away the case will be seen by the specialist or ONG unit in the hospital. See how powerful the midwife of Malaysia are with the, we say that with the power given by the doctors of Malaysia lah. Okay, strategies for promoting maternal care. Okay, as we know, I told you, all this care is being given. Okay, and then how do we monitor that the care is being given or rendered well? We have got a checklist, we got lots of checklists, we got standard operative procedure, we got guideline, we got local and international, local and national audit, we got quality assurance program, we got CEMD report, we got clinical practice guidelines. So we are governed by all these document tools to ensure that our care is of quality. Okay, what happened is how we became even better. The strategy was upgrading the midwife curriculum from certificate to diploma program. Okay, so from certificate, we started not only in the government, but also in the private sector, we started advanced diploma in midwifery nursing. And this particular program was measured by the training division and also by the chief obstetrician of Malaysia. That time it was Dr. Ravichandran Jagannathan and his team lah. They measured the program, and it was found that the diploma midwives could perform better than the certificate midwife because they've got critical thinking, problem solving, analyzing, and also problem solving. So we still carry on with that lah, with that program. Okay, we also have credential and privileging. Once the midwife has been trained, finished training, they won't be put back in their previous departments such as medical, surgical, orthopedic, and so forth. So under privileging, they'll be put back in the obstetric and gynecology unit or in the community clinic to serve, so that they can use their knowledge into transform it from theory to practice, transform it into experiences, and they become leaders of the mother and child health care. Okay, then ongoing updates are also given to all these midwives, okay, other than the doctors, the midwives, the other paramedic. So they undergo continuous nursing education, continuous medical education, so many courses. We could, some are not included here lah. So they have to update themselves with cardio, pulmonary resuscitation courses, neonatal resuscitation program, obstetric emergency workshop, obstetric drill station, baby-friendly hospital initiative, episiotomy workshop, cardiotocography workshop, pathograph workshop, okay, initiated by the doctors, and we are in their group. We are not handmaiden, but we work together with them, okay, as midwives. Okay, and then a proper use of guidelines. So we got a lot of guidelines, as I told you. So there is no way for quality deficit. So we also got the garis panduan perkhidmatan prakehamilan di penjagaan kesehatan prima. So this guideline is used for couples who has set up a family, and then to monitor them whether they are fit enough to conceive, or if any difficulties, okay, anticipate the difficulties, then to conceive lah. So this guideline is one good guideline. Okay. There was a research done by the public health research by this Rosaima et al. What this research was exploring the determinant of pre-pregnancy care services usage among reproductive ages women in Kedah, Malaysia. What it concluded is many of them do not know that such a service is available, that is pre-pregnancy service or pre-conceptual counseling service is available. Okay, so what they say is, it concluded they're not aware of it, and it should be advertised lah, so that Malaysians can capture that and have a better fertility this thing lah. Okay. Okay, and then once you see, after putting up a family, they will be looking into fertility, their family fertility. So just now we spoke about going for pre-conceptual counseling. Okay, when they are well, okay, they'll go into setting up their family. They will conceive lah. Okay, otherwise if they fail to conceive within the first year, then referral to fertility program lah. A lot of clinics are there, fertility clinic in the government, in the private, okay, and then they go for counseling, then they go for procedures, okay, for fertility. Okay, when they're pregnant, so this is one of the strategy for ensuring that early booking, to ensure that early booking is done to confirm the accuracy of gestation. So they will be given the antenatal card. This is what we call booking lah. So once confirmed through ultrasonography, okay, the pregnancy is confirmed, then they will be given a antenatal card. So care can be done, this antenatal follow through could be done at the community clinic, okay, government or private hospital, anywhere they want lah. Okay, and then here again, the empowerment and autonomy of midwife in maternity care. Okay, they will be handling all the normal antenatal care, and then intrapartum care, and then postpartum care, the normal cases. Okay, if any the difficult to reach client will be services will be offered via the midwives to their homes. So this is another special agenda of Malaysia. Okay. Okay, this is the card, early booking, early pregnancy booking. This is the record kesihatan ibu antenatal card, and you can see here just now I spoke about color coding. White means very, very low risk. Okay. So there is a buku panduan again. You see, it's a good strategy and training module on how to record the antenatal card. Okay, everything A to Z is recorded there. Okay, and then here the color coding. White is low risk, green is level of care. That means white is very low risk, green is low risk, yellow is that is mild risk, and yellow is mild risk, and red is high risk. So they'll be managed accordingly lah. Okay, and be referred to the hospital. Other than that, okay, they have got this garis panduan senarai semak bagi penjagaan kesihatan ibu mengikut sistem. Okay, this is the training module, or what's that? A book. This is a book. Guideline is a guideline or a book. Guideline book to inform the nurses on how to do the color coding. Okay, if it's white, if they, what are the cases? Okay, how do they take the white, the green, the yellow, and the red. Okay, so this is the green. So there is a mild risk. Okay, so appointments are given based on the condition of the patient. Okay, or mother lah, pregnant mother, not patient lah, pregnant mother. Okay, after I tell you on what is the schedule. Okay, care at community level. White, green is at community level. Yellow and red at hospital, seen by the medical officers at the clinic kesihatan or community clinic or referral to the hospital. Okay, when it is red, definitely the medical officers or family medicine specialists from the community clinic. The advancement in Malaysia, we do have family medicine specialists even at the community clinic. We must thank our government lah for having done that. So our family medicine specialists would handle the case at community clinic, and then if there is help required, then they'll be referred to hospital to be seen by the specialist. Okay, this is the midwife's autonomy of referring case with the referral letter. Okay, of course we are looking into safe motherhood. Safety of mother, safety of baby. Okay, this is to prevent preterm delivery. This is for safety of mother and also to prevent preterm delivery and complication. Okay, so there are also other guidelines to reduce preterm babies. Okay, risk management strategies to reduce preterm babies. So many guidelines. So there is one guideline on hypertensive disorder in pregnancy, gestational diabetes mellitus guideline. Okay, so a lot of guideline here. And also we got strategies from strategies to reduce this risk of preterm babies for grand multipara, unwanted pregnancies, polyhydramnios, and many other problem. We also have got a strategy to mature premature fetal lung. For example, this autonomy is given to the midwife at the community clinic on how to give the dexamethasone to mature the fetal lung before being transferred to the hospital for delivery. Okay, and then strategy and management of pregnant women with anemia. Okay, we have a classification of anemia, and also there's a study in Malaysia done in Malaysia, that is anemia among antenatal mother in urban Malaysia. This is town, and they found that there were anemia among the urban mothers because of urban poverty. So urban poverty, so they recommend that urban mothers should also be looked into carefully to assist them, to help them to prevent anemia in pregnancy. Okay, all these effects of anemia, these are the effects of anemia. Okay, and then what is the strategy? We advise them on good diet. We provide them iron supplement. Okay, because we don't want any maternal complication, fetal complication. That's the thing. Okay, just now strategy in management of a hypertensive disorder in pregnancy. There is another training module here. Okay, see, our strategy is very good. Okay, we are very updated. So we manage the hypertensive disorder in pregnancy right from the antenatal, from the community clinic to the hospital and also postnatally. Okay. And then we also give the autonomy and empowerment to the midwife in administration of magnesium sulfate. Okay, in cases of severe preeclampsia, impending eclampsia, okay, before coming to the hospital. This is to prevent complication to the mother and the fetus. Okay, we also have got strategy in management of gestational diabetes mellitus women. As I told you, we follow the guideline. We also promote health education not only to the pregnant woman but also to the family. Okay, and then health education is given to identify risks. Okay, so once they identify, when we give the health education to the woman, they identify the risk, they come to the hospital. Okay, parental public forum is also given. So we have got lots of agenda. So next is determining place of delivery, where to deliver. Of course, hospital delivery is the best lah. Okay, this is based on studies lah. Okay, and when the cases are normal, okay, we anticipate normal delivery. Okay, should there be any risk of postpartum hemorrhage? Okay, we have got a guideline here. Okay, so everybody follow this guideline and then led by the obstetrician in the labor room. Okay, so they are always there. Every shift there's a specialist. So no problem with the specialists, medical officers, housemen, midwives, nurses. We have got a very big team, though there's shortage, but we'll manage the case well lah to prevent complication to the mother. Okay, and then we also promote alternative birth center. Okay. Actually, it's a very beautiful area. Okay, it is a midwife-led center. Okay, just like overseas, no, we have got this system here. Unless there's a problem, then we bring them to the hospital. Okay, so we have got this guideline on how to manage the alternative birth center, which is very, very clearly stated. So there's no way to breach the standards. So we use the photograph, and if there is any abnormal recording, then we refer to the hospital immediately. All right, is there a place for home delivery? Okay, right now in Malaysia, we don't lah. Okay, so there are goods and advantage and disadvantage of it lah. So they say that most obvious drawback is not everything a hospital offer lah, they say. Okay, you may need the expertise of the hospital and certain equipments at the disposal if something goes wrong. So to resuscitate, we don't have equipment, resuscitation team and equipment in the hospital. At home, there's always the possibility, no matter how small, a tragic complication which could have been more effectively dealt in hospital. So parents choose home birth, okay, will consider and come back in terms with their risk lah. Okay, so in Malaysia, most of them go to the hospital lah. Nobody wants the home delivery. Studies on home delivery, hospital birth, home birth. Okay, it shows that there's a Cochrane review here lah. They say that both also has got risk. This particular Cochrane review. All right, and then it also states that home birth has got a risk of 1,000 increase in stillbirth and 400% increase in neonatal seizures. Okay, then followed by postnatal care. We have got another guideline here, how to manage the postnatal mother at home, in the hospital and also at home. And then we also provide postnatal home visit. Okay, and also we also has got a guideline on provision of prophylaxis heparin to the mothers who require this lah. For example, cesarean section, obesity, everything was that entered in this guideline on how to give. So when they're admitted to the hospital, okay, they'll be advised on the the injection of this low dose heparin. Okay, when they're discharged, the advice would be they'll be seen by the pharmacy. See, this is another special area whereby nurses are good, but the pharmacy is even better. So they'll be seen by the pharmacies and advice on how to inject this heparin. Okay. So this heparin was started quite some time back in 2009, and they found that with the provision of heparin, okay, maternal deaths, okay, due to obstetric embolism reduced. Okay. Okay, after that, okay, postnatal over. Now we are looking into their fertility, fertility, control of fertility. So we provide family planning based on guidelines. So we use the WHO, medical eligibility criteria. So we have got the English version, the Malay version, okay, and then we have got this guideline which would be discussed with the couple, and we help them choose the best for them lah. Okay, so we got this protokol pengendalian amalan perancang keluarga yang berkesan di kalangan pelanggan berisiko di peringkat penjagaan kesihatan prima. So we also has got a lot of protocol. We have got the medical eligibility criteria from WHO, the translated version of Malay in Malaysia. We got this protocol, okay, for them to control their family. Okay, so they've got variety here. You can see pills, injectable, IUCD, barrier method, implant-on, And also we have got natural method, which we don't advocate, because natural method can be a failure and we may end up with unwanted pregnancy, okay, and then all the other complications to the mother and also to the baby. Okay, this is the medical eligibility criteria will for contraception use. So we have this in the clinic. And these are all the guidelines that is available in Malaysia. So we are really actually having lots of guidelines, standards, okay? That is why we are, our maternal mortality rate has reduced, okay? Perinatal mortality rate has also reduced, okay? So mother and child safety is utmost important, okay? Okay, monitoring child growth and development, okay? This is at the, when the child is born, okay? So how do we monitor? We monitor their growth and development from home and also at the school. Okay, one of the strategy is, okay, we also provide immunization. Our coverage is more than 95%. About 2-3% people may not want to vaccinate. Okay, vaccinate, but we give them counseling for the vaccination. Okay, so in 2019, we have more than 95%. Okay, this is the national immunization schedule, which all the clinics and also the private hospitals adhere to lah. Okay, in control of communicable disease. Okay, so here this boy, so daringly looking at the injection. I love this picture. Okay, future doctor. Okay, this is oral polio. All right, this is school health program. Okay, after when they are until 6 years old, they'll be monitored at home and also at the clinics. And then 7 years until 17 years, they'll be monitored at school level, primary school and secondary school. All right, so dental services are also provided. And health education is given. Okay, right now we got to COVID, health education on fixing of masks, okay, and other things. Okay, now we'll discuss on management of pregnant women and children in COVID-19 pandemic. Okay, lots of these guidelines have been taken from the Ministry of Health. Okay, okay, it continues lah. You see, antenatal and postnatal care continue with appointment. If the pregnant mother is symptomatic or self-isolated, routine appointment is postponed lah or deferred to 14 days. So we also identify missed appointment to continue care and advice to ensure needs taken care of. Mothers, sometimes pregnant women are scared to come to the clinic, so we manage them lah. Defaulters, we manage them, we contact them, manage them well. So we also screen women for mental health status to identify domestic violence, coping mechanism, and access to healthcare. All right. So we are also running the services well despite the COVID-19. So as what we say, we modify the system, but we don't jeopardize the quality of care, right? Okay, each unit maintains social distancing while minimizing possibility of infecting others, which includes visiting rule. Safe antenatal and intra-partum care is priority. Safety of workers, healthcare workers also a priority. Mode of delivery of the mothers depend on the mother. If they are infected with COVID, mode of delivery is different. If they are a normal case without COVID, the mode of delivery will be different. Okay, previous norms is overcrowding lah. Current you see COVID-19 norm appointment based on visit. So they will phone, they will use their telecommunication system, call, and then fix the appointment and come to the clinic. Okay, we also has got virtual services partially implemented lah. Okay, virtual prenatal care visit. Okay, they will call the hospital, they'll call the clinic, fix appointment, they will come over. Okay, so we also, when we already book the mother and there is any problem, we also empower, give the autonomy and empower the patient to measure their weight, to check their weight, blood pressure, the fetal kick chart, to determine the health of the well-being of the fetus in utero, blood sugar all at home, and they will report to us lah. And then next, we also provide consultation. The specialists will be at their service lah when they need. And then virtual postpartum visit. Okay, not only they do home visit, they could also be monitored via the virtual postpartum visit, and lactation support face to face and also through the telephone. Okay, phone. Okay, the modified process of maternal healthcare. Okay, what they do is they scan the QR code, and then they fill in the personal data to reduce waiting time at clinic and also to reduce risk of exposure to high risk cases lah. Okay, and then they make appointment with community clinic, and visit is not jeopardized. Still 8 to 12 weeks. The first visit, okay, to determine accuracy of POG. Then they do COVID-19 screening, then booking, then anthropometry, followed by blood investigation, physical examination, RME by medical officer, checking of lung, heart, and ultrasonography, health education, and supplement, iron supplement, and then they're given to come again appointment lah. So the procedure goes on as usual, but by appointment base. Okay, this is the antenatal clinic visit. Pregnancy to 28 weeks period of gestation, monthly. 29 to 36 weeks, 2 weekly. 37 weeks to 40 weeks, weekly. Above 40 week admission. Okay. Abnormal cases visit is different. It'll be weekly or 2 weekly. Okay. Examples such as wrong date, unsure of days, anemia, gestational diabetes mellitus, hypertensive disorder in pregnancy, IUGR, and others. Okay. Okay, the RME schedule, medical checkup by the routine medical checkup by the doctor. The first we have got, last time we used to have one. So the modification to ensure good care to the mother and the child. So first examination is between 12 to 18 weeks. Second, 28 to 30 weeks. Third is 36 to 38 weeks. Okay. And then compulsory GDM monitoring okay, is done to reduce risk of miscarriage, fetal anomalies, unexplained IUD, hypoglycemic and hyperglycemic attack, IUGR, preterm labor, macrosomic babies, and PPH. And then modified GTT is done twice, 18 to 20 week first, second is 28 to 30 week and more. Another one more extra if mother is not, the sugar levels are not under control. Okay, the guideline for frontliners, okay, we also has got a guideline on use of PPE. We give them training to prevent coming in contact with the disease. Okay, training of donning and doffing. So this is guideline on management of pregnant women at hospital. Okay, this is where I work lah, with our specialists and specialists and midwives. This in the southern zone of Malaysia, Johor, HSA, Hospital Sultanah Aminah. So temporarily suspended activities. If the mother is with COVID-19, okay, okay, we hold the baby-friendly hospital policy, and also spouse is not allowed lah to be with the birthing mother. Okay, mode of delivery is cesarean section. Okay, to prevent transmission of infection. Okay, the mother come in with the dilatation of os fully open, then vaginal delivery. Okay, with strict guideline following the SOPs. Next, woman to use surgical mask, shield, staffed with full PPE with an N95 mask and a face shield. All the body fluids, specimen, placenta is disposed based on universal precaution. Okay. Okay, screening of procedures. Okay, mother is screened at the patient assessment center. Okay, and then this includes all the mother, whether COVID or not. Okay, they've got this form to fill whether they have come in contact with any COVID-19 patient, so that if there is any contact with any symptom, then they will be specially investigated. with the PCR. Okay, delivery of baby will be with a mask. Breastfeeding, this is normal case, not the COVID case now. Okay, with a mask also, breastfeeding. Okay, normal case. Okay, what's new? Okay, it is vaccination of pregnant women in Malaysia. Okay, Malaysia found that we had 3,396 cases of pregnant women with COVID. Okay, in 2020, there wasn't any death. In 2021, there was 70 deaths. So the government, okay, with the KKM specialists, all the specialized doctors, they joined together, put their hands together. They started, based on the overseas evidence, they started giving vaccination. Okay, this one I stated already just now. All right, they started the vaccination. All right, and then now 57%, 83,251 has received the vaccination at least once, and 20% are fully vaccinated. Okay. All right, all type of vaccination, these three type of vaccination can be given. Pfizer, AZ, Sinovac, equally good. That's what we believe lah, because that's we based on evidence. Okay, vaccination is also given to mothers who are breastfeeding. Okay, the next will be modified postnatal care schedule. Okay, once upon a time, we visit the mother day 1 until day 20. Okay, now we have modified. Okay, day 1 is at the hospital, day 2 at the hospital, day 3 we visit by the community clinic nurse to monitor, to assess the mother, the baby. Okay, day 3, day 4, day 6, day 10, day 15, day 20, and then everything normal, let them be there. If anything abnormal, refer to the hospital. And 1 month later, we refer them to the hospital for RME. Okay. Next will be child health. It's a modified child health care lah. System change, but quality remain, as I told you all. Okay. Last time, children will be gathering together. Okay. Now you can see social distancing, masking. Okay. And then e-learning starts at home, not only at school. Okay, when disease is at the peak, okay, they study at home. Disease down, they go back to school. We follow, okay, because evidence show that it could be done. Okay, this is e-learning by the student. Okay, strict SOPs at school, screening. Okay, and then good hand wash, social distancing is applied. And then a school health visit, okay, has been transformed, okay, to modified to clinic visit. Now the school children go to clinic based on a telephone appointment. So they're given the same monitoring and management. So when they're at the clinic, anthropometry is done, physical examination is done, immunization is done, health education. And if there's a need for referral is done. So as again and again, I would say that Malaysia does not compromise quality. We keep up to our quality. Okay. And we also has a guideline on COVID-19 vaccination for adolescent. Okay. So 12 to 17 years. So this is also new, which is very, very, we are proud to say that we are really we really upkeep our standards with the WHO standards. Okay, they say children are less infected, okay, than adult. Most of the children and adolescents that were infected had mild or no symptom at all. Some children and adolescents had severe disease and few died lah. So many of them have underlying chronic condition, medical condition that predispose them to severe illness and more likely to develop complications from COVID-19. So children and adolescents with COVID-19 are at risk of developing rare but serious conditions such as multi-system inflammatory syndrome in children. Okay, they mimic the disease, Kawasaki disease. Kawasaki disease shock syndrome and toxic shock syndrome. So the clinical features are fever, hypotension, GIT problem, rash, and myocarditis. So what is new here and what we are proud of is vaccination has started at school. Okay. Excuse me. And our figures of COVID looks very, very promising, going down. Okay. Hopefully, yeah, it'll diminish within a month or so lah. We are praying for that. So again, in summary, I like to conclude that provision of maternal and child health care in Malaysia is of high quality. We got good guideline, good SOPs, okay? And then we got a very good team headed by our consultants, medical officer. We got collaboration with other departments, okay? And the midwife work hand in hand. They're not handmaiden, but they join together collaboratively. They decide on the management of patient, okay? And they come up with good obstetrical management, okay? All right, that's all. These are my references. Okay, thank you very much. Okay, open to question.
Thank you so much, ma'am, for giving your valuable insight on health promotion strategy on pregnancy, woman, and child. All right, now we're moving to the next session, which is question and discussion. We will go ahead and take some time for question. All right, ma'am?
Yeah, okay.
It looks like we have a few questions from the audience.
All right.
In the chat box. You're the first question, ma'am.
In my chat box, huh? Okay, let me see the question.
Yeah. The first question is from Ayu.
Okay.
The question is, based on your explanation, there are 4 categories of normal to high risk pregnancy risks. How to classify it? How is the health promotion strategy applied in Malaysia for each of these risk pregnancy categories?
Okay,
is the question clear enough, ma'am?
Okay, thank you, Ayu. Where are you, Ayu? Please raise your hand. I want to see where is Ayu. Mana Ayu? Ayu, mana kamu?
Ayu, maybe you can.
Ayu.
Mana
Ayu? Saya nak lihat Ayu. Ayu tidak ada.
Ayu dari D4 mungkin bisa di-on-cam.
Ayu tidak dapat lihat Ayu,
Maybe she's the shame, ma'am.
Oh, dia malu Ayu malu Sekejap Ayu I nak tengok today punya ni berapa ramai datang. Okay, wait start video. Sekejap Okay, Ayu, I'll answer this question. Okay. Just now I showed you there's a guideline, okay, on color coding by the Kementerian Kesihatan Malaysia, okay. They will write in the color coding, okay, white. What are the problem? How do you code the white? Okay, there's no problem, so you color code the white, okay. Okay, for example, green, okay, example of green, example I give you, okay. There will be a range of conditions whereby a green tag is required. Okay. An example of green I could give you is overweight. Okay, mother is overweight. Okay, when we check the BMI, she has just come to the clinic with pregnancy. So when we check the BMI, she's not obese, but she's overweight. So this overweight can be a risk. Okay, overweight can be a risk to the pregnancy. So we'll tag green. All right. Okay, yellow, for example, if I'm mistaken, yellow. Okay, maybe she came in with a previous history of hypertension. She is a pregnant woman, but she has got hypertension, essential hypertension. So she came in with hypertension, okay? And this essential hypertension, this is before pregnancy, she already having it now. And this can transform into hypertensive disorder in pregnancy. So we'll be watching her closely. That's a possibility. Okay, along the way, okay, BP is controlled with medication, well controlled. Okay, good. She go into delivery at 37 weeks. We don't want to prolong lah. Okay. Should there be any complication along the way? Okay, suddenly there's a sharp rise in BP. Okay, severe, they may diagnose her with, okay, she has got high BP. Okay, next, urine albumin, presence of albumin in the urine. Okay, and then she has got edema, so she has got severe preeclampsia. Okay, or she may say that, okay, with all these clinical manifestation, plus she say, I'm having blurring, I'm having a severe headache. Okay, it's already impending eclampsia. Straight away, a red tag will be tagged on the red card, on the antenatal card, and referred to hospital immediately, seen by the family medicine specialist at the inform this referral letter done by the family medicine specialist or medical officer at the clinic, community clinic, and referred with a staff nurse, okay, and medication. If she need a magnesium sulfate being given and transferred. Okay, so it's white, green, yellow, red. I gave you a good example. Ayu, have I answered your question? Masih tak nampak Ayu? Mesti cantik ni Ayu nama dia. Ayu.
Yes, thank you so much for your answer, Miss. Sorry, I cannot open my camera because there is a problem with my video setting.
Okay, no problem, Ayu. Okay, have I answered the question? Ayu, senang hati tak jawapannya?
Senang, thank you so much, Miss Mariam.
No problem, my dear, my pleasure. Okay, Wija, any more?
All right. Yes, ma'am. There is one more question, ma'am.
Okay.
From Nadia.
Where is it?
The question is.
Okay, Nadia.
I will read the question, ma'am. I will read the question. All right. In Indonesia, health promotion is burdened by access, especially for remote area in several archipelago where we separate by the sea. Is there any strategy in Malaysia to solve this particular problem that we can adopt in Indonesia? As we know that Malaysia also an archipelago country, right?
Yes. Okay. Okay, what is this girl's name, Nama dia siapa tadi? Nadia.
It's from Nadia. Nadia,
where are you, Nadia?
Hello, ma'am.
Cannot come and see me. No problem, Nadia. Nadia mana? Tak nampak. Okay. Dia malu. Okay, tak apa. Nadia, just now I remember, I told autonomy and empowerment. Okay, autonomy, you see, we have got urban. Urban is bandar lah. Rural is dekat kampung-kampung. We got lots of kampung in Sabah and Sarawak. Okay, so how we reach them? So it is difficult to reach people lah. But how we reach them? We got a system lah. Still, all this we have got guideline. Okay, we have got the doctor-patient ratio, nurse-patient ratio, and mode of reaching them. How to reach them? Is it by land? Is it by sea? Is it by helicopter? You saw one midwife coming down from the helicopter. That is how we reach. So we try our level best. And then besides that, okay, we have got little clinic desa. Clinic desa catering for the health of the community. Okay, now it has this clinic desa, and then a few clinic desa is being controlled by community clinic, clinic kesihatan. That one besar, big one. So any problem, they will contact this particular clinic to get help. Okay, and these clinics are also contact the hospital, and especially Sabah, Sarawak, especially the ferry, they use a lot of telemedicine. Telemedicine, for example, they got a problem, they'll be online already. Okay, discussing with the doctor, not only one doctor, several area doctors. Okay, to manage the case appropriately, so that case managed well, and then followed by stabilizing the patient and transferring the patient to the nearest clinic or hospital. Nadia, sudah jawab soalan tak? Sudah.
Thank you for your answer.
Puas hati ke Nadia jawapan tu? Tidak dengar Nadia.
Apa jawabannya udah jelas?
Jelas. Tidak apa. Nadia tak dapat sebab Nadia mungkin ada problem dengan line. Ya, line problem always happen. I understand. Okay, and then another one more thing also, resources very important, because you know why? We have to have enough money, okay, enough personnel, enough structure, and then appropriate system, okay, for the work to be done lah. That's all I could say. Okay, next. Okay, sudah habis kah?
Right, ma'am. I think there is no more question in the question box, ma'am.
Alright, very good.
Yes, maybe that's all. You already answered all the question very clearly, ma'am.
Very clearly, thanks.
Yeah, very clearly, thanks. It
Okay,
looks like we've covered all the question, ma'am. Is there anything else you wanted to cover up before we wrap up?
I think, you know, I've had quite a lot of slides. That's why I went through a bit fast. So I apologize for that. Because in my letter, in my call letter, it was stated 9 to 11. That's your time. My time will be 10 to 12. So I prepared slides for 2 hours lah. But when I came here, I got a shock. It's only 45 minutes. So, but I must cover because it is like a flow, you see. Anyway, a bit fast, but it was, I've given the slide to Dr. Kisa. You all can get access to it if you think it is important. All right?
Yeah, it's clearly, you
Clear,
already explained it so clear,
okay,
ma'am.
thank you,
so much.
Vijay. This is what we do in Malaysia. I really salute my Malaysia, not on our health minister, and then our health system, especially the ONG department. Okay, headed by very powerful people. So we also collaborate, government and the private, the hospital and the universities. We work together for realizing the agenda, objective of the government. Thank you.
Thank you, ma'am.
All
now
right.
we come to the conclusion, ma'am.
All right.
I will read the conclusion.
All right.
The clinical governance is the framework through which healthcare organizations are accountable for continuously improving the quality of their services and safeguarding high quality of care. One of these initiatives is 6 pillars of safe motherhood, which are family planning, antenatal care, obstetric care, postnatal care, abortion care, and STD or HIV cancer. To ensure these 6 pillars achieved and decrease maternal and neonatal maternity rate, empowerment and gift program to increase knowledge to all healthcare, especially midwives, is used. With this, we hope that we can reach the third goal of SDGs, which is ensure healthy lives and promote well-being for all at all ages. Or we can call it to ensure the life from womb to tomb. That's it for the conclusion. I think we're good for now. Thank you for the audiences for being so active in this first topic of guest lecture. And also massive thank you to Mem Maria Mamasalamani, first speaker today, for her insightful presentation. Thank you once again, ma'am.
Yeah, thank you.
Thank you so much.
All right. So can I leave, Vijay? What is the program? Maybe. What is the program like, Dr. Kisa?
There is another agenda from today, Miss. Ma'am, right. After you present your presentation, also there is Ma'am Jolie from Philippines and also Miss Firly Imaniar. But if you have any other agenda outside this, you can leave the meeting, ma'am.
Okay, never mind. I stay to see what are the updates in Philippines. Okay, thank you very much.
All right. Thank you very much.
Thank you so much. All right.
Thank you.
I'll join you.
All right. Now I will give it back to Miss Radinta Jasmine as the Master of Ceremony.
Okay, thank you for Dwi Jessica Firdaus. Participants, please kindly turn your camera on and mute your microphone. Also, don't forget to fill the presence form to prove your attendance. But no need to fill it twice. Listen mindfully and feel free to ask questions. Furthermore, we will enter the second speaker delivering Kuliah Tamu material with the theme Women Empowerment to Enhance Women's Equal Rights in Marriage and Family Relations, which will be led by Hafidatul Ilmilah Parera as moderator. Ladies and gentlemen, I present to you Hafidatul Ilmilah Parera. She's a midwifery student and she is really into gender issues, including gender equality makes her the perfect match for Miss Maria Giri Jordan, PhD NSC, to talk about women's equal rights in marriage and family relations. She's experienced being a speaker of midwifery webinar, Indonesian Youth Generation and Future Planning Health Reproduction in 2020. With her newest achievement is first place winner of GSM EXI fact sheet in 2021. For her video tour Ilmila Parera, please, time is yours.
Okay, thanks a million, Radinda Jasmine. Does my voice sound clear enough?
Yes, enough.
Okay, thank you. All right, ladies and gentlemen, I have your attention, please, because our second panel session is about to begin. Thank you very much for preparing yourself to join our virtual conference. Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. First of all, I would like to thank Tukat for his blessed we could gather in this activity in such of a marvelous day with a great presenter, audience, and great virtual place. Good morning, ladies and gentlemen. How are you this morning? I hope we are in a good condition so we can gain a million knowledge together in this forum. First thing first, respectable the Director of Health Poltekkes of Health Ministry Malang, Mr. Budi Susatya, SKP Kemenkes, respectable the Head of Midwifery Department, Mrs. Herawati Mansur, SST MPDMC, and the Honorable, our speaker in this session, Mrs. M.R. Curly Jordan, PhD NAC from Philippines. And thank you for all your presence, all presenters, all lecturers, all academic staffs, and as well as our participants. So dear participant, I'm Hafidatul, or simply Fido, the moderator of this session. In advance, thanks for the Master of Ceremony to introduce me further. With my humility, I'm very grateful to be able to accompany you in this session. So the second panel session is about women empowerment to enhance women's equal rights in marriage and family relation. Such an incredible title, right? But don't worry, in order to discuss very hot topic in this time, we have a marvelous presenter, the Honorable Mrs. M.R. Curly Jordan, PhD NSc from Philippines. She is one of the lecturers at St. Paul University, Philippines. And to know more about her, let's read the curriculum vitae about Mrs. Curly Jordan. Okay, please, for the committee, display the curriculum vitae. I'm sorry, for the committee, please display the curriculum vitae from Mrs. Curly Jordan. Okay. First thing first, we know about the personal profile of Mrs. Maria Curly Jordan, MS and PhD NSc. She is a committed faculty member in the School of Nursing and Allied Health Science of St. Paul University, Philippines. Proactive lecturer with 30 years teaching courses on undergraduate and 10 years on postgraduate levels, dedicated to mold students to be committed, compassionate, caring, and good-fearing future professional. Oh, it is such a visionary goals. And we jump to the next achievement. She has the newest achievement here is coordinator International Nursing Immersion and Graduate Nursing Learning Center. And we have the history of her education here in St. Paul University, Philippines, in doctoral degree in Doctor of Philosophy in Nursing Science with the title PhD NSc, and the graduate school in Master of Science in Nursing, GHN major, and then Bachelor of Science in Nursing at 1980. And then we can reach her through kind of platforms. At first, the address at 276 Melilin Street, Palu Lasur, to Guerrero City, Cagayan Valley, Philippines, 3,500. And then we can reach her also through phone at +63 91625034. And this is the email address, and maybe the last is educational email address. And then we jump to her employment career. The newest or the present is Julie at 90 and 91 as a clinical instructor at St. Paul University, Philippines. And then about international engagement as a guest speaker, the newest is International Seminar of Health at 20 and 16 in Malang, Indonesia. And as a guest lecturer, as a community health nurse in a community health nursing and gerontology nursing Sarimulia Schools of Health Science in Banjarmasin, Indonesia. Okay, please give applause for our speaker, and thank you for being such a great person, ma'am. All right. Good morning, Mrs. Curly Jordan. How are you today?
Selamat pagi. Thank you. Hello, everyone. And I'm happy to be back in Malang because I was
Hello, ma'am.
there.
Hello.
I've been there in 2016, so I have almost a week going around for lecture in the nursing, and then a workshop for faculty in the midwifery, nursing, and nutrition. And then I had also a conference with the Association of your Nurses Association in Malang, and also a lecture in the ASEAN cooperation in Blitar. So I miss Malang. You see, if you can see my dress, my cloth material is from Malang. So thank you for the faculty who gave this when I was there in Malang, and I love Malang. Okay, so for the moderator, thank you very much for the kind introduction. And maybe it's time now for me to start because I came late. I thought I start at 10 o'clock. Okay, so welcome everyone. I'm happy to be back in Malang. Okay, so I will begin now. I'll share my screen, my PowerPoint.
Excuse me, ma'am.
Yes.
Before we get started, can I read some regulation for today's material delivery?
Yeah, I have it. I can just share it. And I sent to Dr. Kisa my copy. But I want to share mine because I added some more last night. Okay. So can I share my own PowerPoint here? Although I sent already a copy.
Okay.
Okay. Can I start now?
Yes.
Okay. Thank you. Thank you very much.
Yes, ma'am. Okay. You have 45 minutes to speech, ma'am.
Yeah.
And then we will continue with 5 minutes of question and answer.
Yeah, I think this is only less.
Yeah, okay, ma'am.
Yeah. Can you see my screen now?
Yes, ma'am, we can.
Okay.
Yeah.
So, where is that? Okay. Again, good morning, everyone. So I'm tasked to discuss on women empowerment to ensure the women for their relationship with the family and marriage. So I hope I will give enough discussion on this, and I transcribe it really because I was I was informed that my audience are students, so I transcribe really the PowerPoint so that you can use it for your copy. So I am from St. Paul University, Philippines, and I visited your place. So I saw Malang. I love Malang. Although I went also to the different parts like Banjarmasin, Samarinda, Jakarta, but I stayed long in Malang. Okay. So your president also came here to St. Paul University in one of the conferences because of the signing of the Memorandum of Understanding. And Dr. Kisa was with us in St. Paul University with his doctoral degree, Doctor of Philosophy and Nursing Science. So I'm happy again to be with the Malang group. Okay. So my topic is women empowerment. So I have only a few objectives here. I want to define the concepts of empowerment, women empowerment, and other concepts that will be online with women empowerment, and then to discuss the roles of women in marriage and in family relations. Okay, so as you can see my picture there, a woman with this fist, with her fist. So she must be strong. Okay, so she must be empowered. So actually in ancient times, women were adored and worshipped. Okay, they are considered as goddesses. But then, however, in the Middle Age, women got down to the extent that they experience several negative or disadvantages in the society, and women are considered in the society only to perform duties like bringing up children, caring every family member, and other household activities. And there is this old and traditional faith of people coming out for years that men are the ones working outside the home and women are the only ones at home. And nowadays, women are breaking all the barriers of social issues and problems against them in the society. So we're trying to get out from the scenario. Okay. So I want to define first empowerment. So when we say empowerment, it is the process of increasing the authority and responsibility of individual or groups to make choices and to transform those choices into the desired actions and outcomes. Okay, and when we define women empowerment, it refers to the increasing the spiritual, political, social, or economic strength of women, which often involves the empowered individuals to develop and to foster confidence in their own capacities. And another meaning for women empowerment is fostering of a woman's sense of self-worth, her decision-making power, her access to opportunities and resources, her power and control over her own life inside and outside the home, and her ability to affect change. Okay? And there are several components of empowerment. We have women's sense of self-worth, the right to have and to determine choices, the right to have access to opportunities and resources, the right to have the power to control their own lives both within and outside the home, and the ability to influence the direction of social change to create a more just social and economic order that is nationally and internationally. And it also enhances self-esteem and self-confidence in women, build a positive image of women by recognizing their contributions to the society and economy, develop in them an ability to think critically, and to foster decision-making and action through collective process. Another one is enable them to make informal choices in areas like education, employment, and health. Ensure equal participation in the development process, provide information, knowledge, and skill for economic independence, and to enhance access to legal literacy and information related to their entitlement in the society with a view to enhance their participation on an equal footing in all areas. Advantages of women empowerment is the next generation will be empowered because of her. So there will be what we call a succession from the next generation, that when we start to empower women, then it will go along. Okay, and if women will be empowered, then she will not be a burden on anyone. Okay, and financial burden of man can be shared with her support, so there is a equal sharing of finances. Okay, and family can be stronger because of both working hands, and when financial problem will be shared, and result of conflict will be resolved, especially now with the pandemic. Okay, we cannot just be asking the husband to be working, and sometimes companies close, and so the wife or the woman should come in to help. Okay, and we have common issues and problems here. We have also like selective abortion and female infanticide. So there are countries, it's not in our, I'm sharing this one, it's not in our country, but in some other countries wherein they do selective abortion and female infanticide, especially in the Western countries. If in the ultrasound they found out that this fetus has problems, deformities, they will abort the fetus. Okay, and it's very alarming. And then we have also sexual harassment. This is common, especially for women who goes to different countries, and this is common with the Filipino domestic helpers that go to the different countries. They work as domestic helpers, and most of them are being sexually harassed. And then this is disparity in education, domestic violence, child marriages, teenage pregnancy. Now in the Philippines, teenage pregnancy is very common. They are still in the high school or in what we call the basic education, and they already get married. So they started 13, 14, 15, 16, 17, 18, 19, and as early as that, they get married, which is very, in the researches that were done here in the Philippines, the Philippine Commission on Population is doing something for this, so that this health education is given to these teenage students, so that they will be addressed, so that they will not get as early as the teenagers. Okay, then we have the inadequate nutrition. So malnutrition is still a problem in our country. Low status in the family, and also the status of widows. So when the husbands go first, and actually there are several programs given to them to assist them. Okay, and we have also the sustainable development goals. For goal number 5, we speak about gender equality. And when we say gender equality, is to achieve gender equality and empower all women and girls. Okay, so the objectives there is to create a thorough positive economic stability in social policies for full development of women to enable them to realize their full potential. They should have equal access to participate in decisions such as social, political, and economic life of the nation. And I want to share you this, that women also had the positions for presidents in their countries. Like in Iceland, the first woman president in Iceland, and then in Argentina, in the person of Isabel de Perón, Martinez de Perón, and also in the Sri Lanka, okay, in the person of how they call this, Bandaranaike. Okay, and in the Philippines we have 2 women presidents. Our first woman president was Cory Aquino in the early 20s, and then now we have also Gloria Macapagal Arroyo. So we have 2 women presidents in the Philippines. So that's in the Asian country. And maybe later on, maybe in Indonesia, maybe there will be a time that there will be a woman president. Who knows? And you know what? When I saw your contestant, your participant in the beauty pageant, I really love the way she looks and the way she talks. And I know women in Indonesia are starting also to come out, okay, to come out. Although we say that most of you are Muslims, but then I hope slowly there will come a time that the women also in Indonesia will be empowered, okay? And there will be equal access of women to healthcare, quality education to all levels, career and vocational guidance, equal employment, and occupational health and safety. So it is said there that women and men are the same when it comes to this in the SDG goal number 5. Okay. Continuation on that is the building and to strengthen partnership with civil society, particularly women's organizations, and the strengthening legal system aimed at elimination of all forms of discrimination against women, elimination of discrimination and all forms of violence against women and the girl child, mainstreaming a gender perspective in the development process, and changing societal attitudes and community practices by active participation and involvement of both men and women. And could marriage, okay, contribute to women empowerment? I want to share some cultures like in Africa. For them, marriage is more of buying women, and once the men buy the women, they use them in any way. So it's like slavery and deprivation of their rights. So they can the husband can do anything, because for him, he knows that he bought the woman. Okay, so he can do anything what the husband likes. In the Middle East countries, married women are only allowed to stay at home, and their husbands are the ones working, for the wives are not allowed to go out. So it so happened that I was able to work in Qatar. So I was there for 2 years, and I saw how they treat their women. Their women just stay at home, and you can see in the malls, in all the different companies, you can see that the ones are working are only the male counterpart, but women are only allowed to stay at home, and they're not allowed to get out. So you see how would you feel if you will be like that? Okay. In India, marriages in India are between 2 families rather than 2 individuals. Arranged marriages and dowry are customary. So they are fond of the dowry. So you have when you marry a woman, then I think the woman is the one to give the dowry to the man. So it's very bad. Okay. And then for Indonesia and the Philippines, I researched this one. For your country and my country, we experience the same, that women experience at least one type of violence, like any physical, sexual, emotional, economic violence once in a lifetime. So I read the research from Indonesia that we have the same scenario, that the Philippines also experience this one. Although we are a Roman Catholic, most of our people here are Roman Catholics, but still there are some people, husbands, who do that. So we can still find a few of them. Okay. And then I want to discuss the 3 goods of marriage. This is in line with the Roman Catholic, or in my religion. Okay. So in my religion, as a Roman Catholic, so St. Paul University, Philippines is a Roman Catholic. Dr. Kisa knows that because he has been in the university, and your other faculty or professors, Dr. Wiwin and the others, I forgot the other names, and they are in St. Paul University, and they saw how St. Paul really observed this kind of like when we talk about marriage. So I want to share you this one. So the first one is marriage as a sacrament, meaning that by virtue of the sacramentality of marriage, spouses are bound to one another in the most profoundly indispensable manner. So it is considered that the celebration of marriage between 2 Catholic faithful normally takes place during the Holy Mass because of the connection of all the sacraments with the Paschal mystery of Christ. And then we have the sacramental celebration of marriage. The sacrament of marriage begins when a man and a woman stand before God and their fellow men and women and freely and publicly declare. So that's why we have this a marriage vow celebration inside the church, and it consists of what we call godmothers or godparents and the relatives and all the friends to witness the celebration of the marriage. So the marriage activity is to be one of heart and one soul from this day forward, for better or for worse, for richer or for poorer, in sickness and in health, until death do us part. So that's the way, that's the word, the very words that they will utter when the priest says, before they put on the rings, when the husband put the rings on the wife's finger, and the woman puts the ring on the husband's finger. So that's the very words that they will utter. So they will not separate, they will be one. Okay, they will never depart. That's the way. That's why our church here does not allow, although the state, so we have the state and the church. The church do not allow divorce, although the state says we allow divorce, but the church says no. So we don't allow divorce in the Philippines. Okay, and then we have the conjugal love and fidelity. When we say conjugal love and fidelity, so love in marriage refers to the deepest, most fundamental reality of human life. And every person finds fulfillment only when accepted as a person, and only such love affirms us in our basic human dignity because it accepts us in our very selves. And marriage is a covenant. It is an irrevocable union between a man and a woman for life, and it is a solemn agreement between a man and a woman where their lifetime commitment is witnessed by God. Okay, and when we say conjugal love, it involves the totality of the husband and wife, a totality in which all the elements of the person enter, and it aims at a deeply personal unity, the unity that beyond union in one flesh leads to forming one heart and soul. So when we say conjugal love, so when we say conjugal relationship, whatever the wife has, whatever the husband has, they will put this together, and it will become one property. So unless if they go to a lawyer and they says, oh no, my property is for only me. But in the Philippines, say when it's a conjugal property, we say conjugal property, conjugal love. Anything that is being received, okay, or being produced by the husband and the wife, they stay in one, and it will be a property for the husband and the wife. Okay. And we always speak about faithfulness. We say faithfulness in marriage means more than just avoiding to commit adultery. So it's not only saying that you don't have to commit adultery. You cannot get another wife for that. Okay, and it also means growing in faith. There is trust between the husband and the wife, and the love in each other, and the marriage union itself. So it came from the word fides, and say fidelity refers to the benefit brought about by the debt that the couple owes to each other. So it's like this is for us. This is we are indebted with each other. Okay, so whatever pain you feel, I will also feel. So it's just they commit with that. Okay, and this means not only keeping from the love making, but paying on the marital debt itself. So what is marital debt? Marital debt is mutual service, sustaining one another's weakness. So when the husband is weak at that time, so the wife gets she will be the one to take over. And when the wife is sick or not feeling well, then the husband will take over with all the responsibilities in the household or in the further economic stability. Okay. And the third one is serving life. When you say serve life, the offspring, especially the offspring, the children. So it came from the word proles, which refers to the primary and obvious good of marriage. And marriage is good by virtue of the very reason for which it was instituted, for the propagation of human species, and this is made possible by the act proper to marriage itself, the one I mentioned earlier, the conjugal act. Okay, so it's like the propagation of the offspring or the children. Okay, so the moment they are married and they have children, then they have to nurture their children in their best possible way. Okay, deeper. I want to discuss about the deeper meaning of marriage so that you will be able to see how it will be suited for the women. Okay. Okay. So matrimony is a sacrament that binds a baptized man and a woman in a lifelong commitment. And the church speaks of marriage in terms of a covenant and not in terms of a contract. So it's not only on the marriage contract that the husband and the wife sign together. No, it's more of a covenant. Okay, so the difference between contracts and covenants is profound. Okay, the contract there is only on paper because the paper shows there that the wife signed accepting the husband and the husband signed also accepting the wife. But in the church, it's more of a covenant. It's not a contract. It's more of a covenant that they should be together for a lifetime. Okay, and the church speaks of marriage in terms of a covenant and in terms of a contract. So it's very clear. Okay, so Christian marriage is indeed the solemn agreement between two people who pledge to commit themselves totally and as whole persons to each other for life. Okay, and the Christian spouses do not merely accept rights and duties, but they give themselves to each other in a total way. So see, it's in a total way. You have to give in to your husband, and the husband should accept that wife, okay, despite maybe the shortcomings. So you have the moment you had that marriage in the church, you have to accept everything. Okay, whether it's a positive or a negative one, and when it's negative, then that's a time for you to the husband to take care and the wife also to be responsible. Okay, so marriage as a vocation, marriage is a calling to a state of life wherein a man and a woman are now ready to live the single state of life and become a couple, one in heart and aspirations. And marriage is the place where God's love is made visible, and the mutual love of the spouses as well as the love of parents for their children makes visible the love of God for his people. And the promise of unfailing fidelity and self-giving love which the spouses make to one another reflects the promise which God made to his people. Okay? So I place here the elements for marriage. So it's a call of God for a man and a woman to get married. It is a mission to fulfill. Go and subdue the earth. That's the command of Jesus, our God. And the first is communion of life between the husband and the wife. And the second is procreation and education of children. See, the first one is the your relationship, the wife's relationship with the husband, and the role that's for procreation, taking care of children, and also the education of the children. And it provides the best condition for the spouses to mature as Christian in terms of their Christian life of prayer and charity. And the effects of the sacrament of matrimony, it means of sanctification. The grace of marriage sanctifies the relationship of husband and wife. Their love is infused with the saving love of Christ. Then the support for education of their children. The sacrament of marriage is also the source of grace needed for the education of the children with which the marriage may be blessed. And along with their commitment is a mission to provide proper good education for their children. Okay, so the practical implications of married love is because husband and wife are equal as persons, they have joint responsibility of becoming one body. Conjugal unity does not come about automatically or by chance, but the partners have to work at fostering this unity between the real, not romantically idealized selves, that is, within the real, concrete limitations of their own capacities and personalities. And the unity and fidelity of marriage is not simply the negative, avoiding adultery, but the positive, growing in faith with each other. And there should be trust and love, believing in the word of one's partner and in the marriage union itself. Okay. This also means responding mutually to the ongoing changes that occur in every human person's life, and consequently in their primary interpersonal relationship, the partners must understand and accept these changes in the personal development of each. And this means developing the ability of community with each other on ever deepening personal levels. Okay, so we have also new national policy for women empowerment. We have to create society with women working as equal partners in all spheres of life, to develop a framework to ensure equal rights and opportunities for women. Health and education of women have been kept as a priority in the proposed draft. The draft is proposed to improve access to pre-primary education, and then carry out skill development and provide equal employment opportunities, provide suitable benefits related to maternity and childcare services, as mentioned a while ago by the first speaker, and then to address all forms of violence against women, to improve child-sex ratio, to prevent trafficking at source, transit, and destination, areas for effective monitoring of the networks. And then we have also policy prescriptions, where I just included these ones: judicial, legal system, we say about laws. So we have also laws about women, and then the new laws will be enacted, reviewed, and to ensure their justice is quick and punish of the offense, and the full participation of all stakeholders, including community and religious leaders. The policy would aim to encourage changes in personal laws, such as those related to marriage, divorce, maintenance, and guardianship, so as to eliminate discrimination against women. And also in decision-making, women's equality in power sharing and active participation in decision-making, including decision-making in political processes at all levels, will be ensured for the achievement of the goals of empowerment. And then the mainstreaming a gender perspective in the development process. So there are policies, programs, and systems that will be established, okay? And then there will be women-friendly personal policies that will be drawn up to encourage women to participate effectively in the development process. And then we have principles to empower women. We have established high-level corporate leadership for gender equality, treat all women and men fairly at work, respect and support human rights and non-discrimination, ensure the health, safety, and well-being of all women and men workers, promote education, learning and professional development for women, implement enterprise development, supply chain, and marketing processes that empower women, promote equality through community initiatives and advocacy, measure and public report on progress to achieve gender equality. And then we have also gender equality, affirm high-level support and direct top-level policies for gender equality and human rights, establish company-wide goals and targets for gender equality, and to engage internal and external stakeholders in the development of company policies, programs, and implementation plans that advance equality. And then we have also for principle 2, pay equal remuneration, including benefits for work and equal, and strive to pay a living wage to all women and men. Ensure that workplace policies and practices are free from gender-based discrimination. Offer flexible work options, leave, and re-entry opportunities to positions of equal pay and status, and support access to child and dependent care by providing resources and information to both men and women. So for principle number 3 regarding violence, so establish a zero tolerance policy towards all forms of violence at work, including verbal abuse, physical abuse, and sexual harassment. Respect women and men workers' rights to time off for medical care, especially when they go for maternity leaves, and counseling for themselves and their dependents. And then to train security staff and managers to recognize signs of violence against women and understand laws and company policies on human trafficking, labor, and sexual exploitation. For principle number 4, we have education and training. So there should be equal access to all company-supported education and training programs, including literacy classes, vocational and information technology training. And there should be equal opportunity for formal and informal networking and mentoring, and offer opportunities to promote the business case for women's empowerment and the positive impacts of inclusion for men as well as women. And for principle 5, for the development of supply chain and marketing processes, there should be expand business relationship with women owned enterprises, including small businesses and women entrepreneurs, support gender sensitive solution to credit and lending barriers, as business partners and first to respect the company's commitment to advancing equality and inclusion, and to ensure that company products, services, and facilities are not for human trafficking and labor or sexual exploitation. And for Principle 6, for community leadership and engagement, work with community stakeholders, officials, and others to eliminate discrimination and exploitation and women, open opportunities for women and girls, promote and recognize women's leadership in and contributions to their communities, and to ensure sufficient representation of women in any community consultation. And there should be the use of philanthropy and grant programs to support company commitment to inclusion, equality, and human rights. And for Principle 7, transparency, measuring, and reporting, make public the company policies implementation plan for promoting gender equality, establishing benchmarks that quantify inclusion of women at all levels, and measure and report on progress both internally and externally using data disaggregated gender. And then for the economic empowerment of women, we have poverty eradications. We have macroeconomic policies and poverty eradication programs that will specifically address the needs and problems of women. And this will improve the implementation of programs which are already women-oriented with special targets for women. And we have the microcredit, establishing new and strengthening of existing microcredit mechanisms and microfinancing that will undertake that the outreach of credit is enhanced, and other supportive measures will be taken to ensure adequate flow of credit through financial institutions and banks so that all women below poverty line have easy access to credit. Okay? And then we have also globalization. There's a need for reframing policies for access to employment and quality of employment. Okay? And strategies will be designed to enhance the capacity of women and empower them to beat the negative social and economic impacts which may flow from the globalization process. And then we have women in agriculture, the programs for training women in social conservation, social forestry, the dairy development, and other occupations like agriculture, horticulture, livestock, for fisheries, and they will be expanded to benefit women workers in the agricultural sector. And then we have also the important role played by women in electronics. So we have also women already in the electronics, in the technology organizations or companies, and also in the industry and textiles. And then they should be given comprehensive support in terms of labor legislation, social security, support services, and to participate in various industrial sectors. And then we have also the support services like childcare facilities, including crèches at workplace and educational institutions, home for the aged and the disabled, that will provide for women to enable them to participate actively on the development process. And then we have also the self-help groups, and this is in India. The project was started within the aim of making women economically empowered by, there are pilot projects in collaboration with partner non-government organizations for empowering women economically and thus helping to prevent crimes against women. Okay, and they have the self-help group. This is formed by the community women with the members like 15 or 20 in such a group, and the poorest women could come together for emergency, disaster, social reasons, economic support to each other, and have ease of conversation, social interaction, and economic interaction. And then for the education, there should be equal access to education for women and girls that should be ensured. And special measures will be taken to eliminate discrimination. So there is universal education, eradicate illiteracy, create the gender-sensitive educational system, increase enrollment and retention rates of girls, and then improve the occupation, vocation, and technical skills. And it says here that education is the catalyst for equality. So if the women finish and then they have a degree, then they have something to be proud of. Reduce gender gap in secondary and higher education, and girls and women belong to weaker section, including backward classes, and minorities will be given focus. And on health, there is a holistic approach to women on health, which includes now nutrition and health services that will be adapted, and special attention will be given to the needs of women and girl at all stages of life cycle. That's from womb to tomb. And the policy reiterates the national demographic goals for infant mortality rate and maternal mortality rate set out in the National Population Policy in the year 2000. And for nutrition, so in view of the high risk of malnutrition and diseases the women face at all the three critical stages, that is infancy and childhood, adolescent, and a productive phase. And there should be focused attention that would be paid in meeting the nutritional need of women at all stages of the life cycle. Okay? And then for drinking water and sanitation, so attention would be for the needs of women in the provision of safe drinking water, sewage disposal, toilet facilities, and sanitation within accessible reach of households, especially in the rural areas and urban slums. And there should be women participation that will be ensured in the planning, delivery, and maintenance of such services. And then we have also housing and shelter. The planning of housing colonies and provision of shelter both in rural and urban areas, and special attention that will be given for providing adequate and safe housing and accommodation for women, especially the single women, the heads of households, working women, student, apprentices, and trainees. For the environment, so there should be an conventional energy resources. Women will be involved in the spreading use of solar energy, biogas, smokeless, chulas, and other rural application, and so as to have a visible impact of these measures influencing ecosystem and changing the lifestyle of rural women. And then the measures and programs will be undertaken to provide the especially in disadvantaged group with special assistance. So these groups include the women in extreme poverty, destitute women, women in conflict situation, women affected by national calamities, women in less developed regions, the disabled widows, elderly women, single women in difficult circumstances, women heading household, those displaced from employment, migrant women who are victims of marital violence, deserted women, and prostitutes. And it says here also the rights of the girl child. All forms of discrimination against the girl child and violation of her rights shall be eliminated by undertaking strong measures, both preventive and punitive, within and outside the family. And this should be a strict enforcement of the laws against prenatal sex selection and the practice of female feticide, female infanticide, child marriage, child abuse, and child prostitution. And then the removal of discrimination, the treatment of girl with the family outside the projection of a positive image of the girl will be actively fostered. And there will be emphasis on the needs of the girl child and earmarking of substantial investments in the areas related to food and nutrition, education, and vocational education. For mass media, it will be used to portray images consistent with the human dignity of girls and women, and the policy should strive to remove the demeaning, degrading, and negative conventional stereotypical images of women and violence against women. And private sectors, partners, and media networks will be involved in all levels to ensure equal access for women, particularly in the area of information and communication technologies. And the media should be encouraged to develop codes of conduct, professional guidance, and other self-regulatory mechanisms to remove gender stereotypes and promote balanced portrayals of men and women. Okay, so we have also legislative reforms, okay, like what we call the marriage succession, domestic offense at workplace, prostitution. So there are several laws for this. And then we have also I'm sharing you this one. In our country, we have the Equal Remuneration Act of 1976 provides for equal pay for men and women for equal works. And we have the GOD policy budget that requires all government agencies to utilize at least 5% of their respective total budgets for programs and activities that address the needs and uphold the rights of women. And then we have also the Philippines Plan for Gender Responsive Development, a 30-year strategic plan that translated the Beijing platforms for policies, strategies, programs, and projects for Filipino women. And these are the framework plan for 2001 in collaboration with non-government organizations such as promotion of women's economic empowerment, protection and advancement of women's rights, and promotion of gender responsive governments. And then we have also Immoral Traffic Act, Dowry Provision Act, and then the Child Marriage Restraint Act, the Medical Termination Pregnancy Act, indecent representation of women, especially in media, and protection of women from domestic violence, Preconception and Prenatal Diagnostic Act. I want to share this Maternity Benefit Act provides for the payment of paternity benefits for women. And in the Philippines, which I have in the next slides, okay? So maybe I will go to that, okay? So these are the salient features, measurable goals by 2010, identification and commitment of resources, structures and mechanisms to ensure efficient monitoring, review, and gender impact assessment of actions, and the introduction of a gender perspective in the budgeting processes for adequate allocation of resources, gender development index that will be developed by networking with specialized agencies working in coordination with evaluation mechanisms. So we have also resource managements like developing synergy between personnel of health, rural development, education and women, and child development department at field level and other village level functionaries. And then for the credit needs by the banks, which I mentioned a while ago. And then the Department of Women and Child Development will be nodal ministry reviewing, formulating policies at highest level. And then we have also the National Council headed by Prime Minister and state councils headed by chief ministers and the state level to meet biannually for progress plans and other issues. So we have also resource centers for women, and then the self-help groups, partnership with voluntary organizations, international cooperation. And then we have also the 12 5-year plan, economic empowerment, social and physical infrastructure, enabling legislations, women's participation in governance, and inclusiveness of all categories for vulnerable women. And what is the role of non-government organizations? The non-government organizations are playing a significant role in the empowerment of women. And there is what we call the voluntary sector that aids more than 10,000 across the country, NGOs across the country, and there will be programs for socioeconomic, vocational training, and other similar programs. And the role of government, we know that the government is very particular with the empowerment of women, especially in the socioeconomic status, okay? And the Declaration of Women's Empowerment that brings a greater focus in the program for women. Okay? And then this one is from India. The scheme provides this 2,500 rupees insurance facility to girl child at the age of 5 years, and from 6 years, the girl will get annual dividend on the deposit, and at the age of 18 years, she will receive 4,410 rupees provided age is unmarried. And this scheme aims at discouraging early marriage. So this is their propaganda on so that there should be no early marriages. Okay, maintenance of 9 destitute colleges where food, shelter, clothing, bedding is provided by the destitute school going children. And we have this national maternity benefit scheme, as I mentioned a while ago. So we have the government insurance, security insurance system, and the social security system, that if you work on the government offices, it will be under the government insurance security system. If you are working in a private firm, you are under the social security system. And the scheme here is you will, if you undergo cesarean section when you give birth, and there you undergo cesarean section, you are given 2 months of your basic salary. Okay, and if it is a normal delivery, you are given 1 month of your basic salary and other what do you call this, benefits that you need to receive. Okay, and then in summary, okay, I want to make a conclusion like that. Women can either make or break a family. See, the very important role of women. You can either, in a family, you can either break or make a family. What does it mean? So with the role of the woman who takes care of the family household, she has a very important role here. So she gives her husband the strength to succeed. She nurtures her children to stay healthy and do well in their life. And she has the ability to take care of every minute detail at home, such as to educate the children, especially now with the pandemic. The mother is there to assist the child
especially for grade schoolers, to assist in the technology like modules. So they are there to assist their children. Okay, and for the college, they are there to see if their children are attending their online classes or not, and then safeguard their home, take care of the household chores, providing nutritious food for the family, and always available to her husband and children, etc. So there are some more. And the role of women in family includes role of a wife, a partner, organizer, administrator, director, recreator, disburser, economist, mother, disciplinarian, teacher, health officer, artist, and most especially the queen in the family at the same time. So you see, you are the queen in the family. And it says here, I want to end it with a saying like, behind every successful man is a woman. And I have some sayings here like, women's empowerment is intertwined with respect for human rights. And the other one is, the empowered woman is powerful beyond measure and beautiful beyond description. Thank you. Terima kasih. Thank you for listening.
Okay. Thank
So that's
you.
all. So I'm ready to entertain questions. If there are questions regarding women empowerment. Okay.
Okay, ma'am. Thank you for delivering the material on time. And I think we have 4 questions here, but maybe we can answer the 3rd question first. If we have more times, we can answer the other question. The first question is from Zumni. As a midwifery student, I'd like really admired with your presentation. This theme was so fun and interesting. Hence, I want to ask for a question. Dear Mrs., as we know that we have to be equally healthy, safety, and free from violence. But what if our people still get into mindset on how women see marriage as a subjection or submission due to their belief and hard to get out from abusive relationship? Kindly to answer it. Thank you in advance.
Yeah, you know what? I've been listening to this. There's a woman, I forgot the name of the woman from India. She was so brave enough that we have to stop this culture. So it's like, it's a culture that women are very submissive. So when they get married, so everything that the husband can ask, they can just do it. But then this Indian woman said, no, it's time now for us to come out in our shell and tell the whole world that women should not just be submissive to their husbands, but they should be equal partners in life. So how can we do it? We change. You know what? Culture is so much. We know that culture is there, but we must try also to protect ourselves. And that culture should be gradually. Well, maybe it's not so in one time that we can do this, but in a gradual manner. We should try to check the culture that's not good for us, especially for women. Okay, so I hope you will the culture, there will be a change in the culture that women should not only be a submissive person, but should be equal partners with their male counterparts. Okay, so like is that okay? Did I answer the question? Who asked that question?
From Juni.
Juni, was able to answer your question?
Yes, Miss.
That we must
Actually,
gradually come out from our the way we believe in our culture. Women now are very vocal, and we can say and shout it to the whole world that we are not just there to be an object to men, but we are here to be equal partners with them. Okay? Is there another question? So thank you for that question.
Yes, ma'am. There is another question from Risa. I'm
Risa
from midwifery undergraduate student. I want to deliver a question. Currently, premarital guidance is a priority to form a prosperous family, includes parenting class, but the implementation is not consistent in our country. My question is, parenting class before marriage can guarantee the decreasing of marital abusive?
You mean premarital sex? Okay. You know what? Our population commission. So we have a company here. We call it a population commission. I know you have that also in Indonesia. We are now giving several programs like health education to these teenage children or teenage students, giving them the importance of not to engage first in sex, or you call your premarital sex, so that they can wait and they will finish their studies. Okay, and then when they finish their studies and they have they reach their proper age to get married, so that they will be what we call, they are ready with their what we call, they are more mature now to face family life. Okay, so I hope you have also programs in your country like that, they go from school to school, giving health education. There are what we call this, they give paper, what they call this, brochures, and then sometimes they discuss in TV. They go from school to school and discuss all these things and share that there is even an what we call this, an advertisement that please do not marry early. Finish first your studies, then so that you must be ready when you get married. So it's like that. It's a very nice advertisement on TV and on radio, that it's always flashed every day, so that these children will listen to this and they will be what they call this, reminded that early teenage pregnancy or early married life, or having premarital sex before marriage is not good. Especially for us Roman Catholics, premarital sex is it's like a part of our culture that it's a no-no. It's a no-no to our culture. Okay, so I hope there will be programs in your country, in Indonesia, that will also address this. Okay, maybe in the midwifery school you can have you can do health education classes here, maybe through radio, especially now with the pandemic. You can do it in through online, maybe classes, webinars, and then tell something or discuss something about premarital sex, that it's better to have to get married when they are still what they call this, virgins. They are still virgins, so that the husbands will not have any question on them and they will not receive any violence later on when they get married. Okay, so maybe that's a project for the midwifery school.
Okay, thank you, ma'am, for the insightful visionary program. And then here we have the third question from Ulfa, midwifery undergraduate student. I want to ask about a question to second speaker. In the beginning of marriage, the often and most crisis is about economy. Why does this happen? That's the question from Ulfa.
The first part, always the first part, the problem is about their economic condition. Okay, so that's why we should emphasize that when the husband and the wife, when the wife gets married, she has something to contribute. Okay, like if she finished a bachelor's degree and start working, then she can also contribute to the husband's money. So there will be no problem in their economic status. So they work together. Okay, so they join their finances. So the woman should work also. No, in the Philippines, you cannot see a woman not working. So the women are also outside there working. They work in stores. They work in schools. They try to get one helper in the house to take care of the children, and then they get out and work outside their house. And from this manner, the wife now can contribute to the income of the husband. Because if you only depend on the income of the husband, then it's with all the bills that we have now, electric bills, water bills, internet bills, with all the bills, it's not enough. And then especially the food every day, the plate that we have there on top of the table every day, it's very expensive. So the contribution of the woman there is to work also and add to the finances of the husband. So there will be no problem with economic finances, especially in the start of having a family. The more when the first child will come out, then the woman should work harder, because it's not easy to bring children without money, because you need to have later on milk. If you don't have the breast milk and not enough for the baby, then you buy, it's very expensive to buy milk in cans, the powdered milk that we give to children, and the things that they need while they are being taken care of from the 0, or what you call it, the 1 month to the how many years, 6 years, because you have to be with them, and then you have to take care of them. And now women, if they cannot get out in their houses to work, they work online. So women can work online. There are many online companies that can get women, the wives, the mothers, they can work in front of their laptop, and they can receive, okay, money, even they will not get out. Okay, so because they are looking after their young children, and they can work at home. Okay, so we have that in the Philippines. They work online, and they can also contribute to the husband's income. Okay, is there another more? Are there more questions?
Yes,
Miss. Thank you.
Yes, ma'am, because we
Yes.
have more time here, so we can jump to the last question
Yes.
from Alia from
Alia.
midwifery undergraduate student.
Mm-hmm.
I want to deliver a question. In unintended marriage cases, is there any tips how to deal with certain consequences?
You know what you call unintended marriage is a marriage that is not being what they call this planned, unplanned marriages. Okay, so you know what, for unplanned marriages, it's more of our part, women. Okay, how do we prevent unplanned marriages? So especially these children now, they are fond of going, you know what, they are very free, like drinking alcohol, going into drugs, and these are the things that contribute to unplanned marriages, because you are not in your proper state of mind, and that's the time the man will what do you call this, they take advantage of us when we are not in our good mental state, like because we are under the influence of drugs, we are in the influence of alcohol, and men can just do anything. And then what we do is, because of what happened, then we go into unplanned marriages, and it will be very detrimental to us, especially as women. Okay, because these men can just leave us anytime if they want. Okay, so it's very important to have a planned marriage. Okay? You have to think about it 100 times before you go into it. You know what? I got married at the age of 30. I was offered 3 marriages, but I turned it down because I think what I have in mind is I'm not ready for it. Okay, so I got married at the age of 30. So it's not, I was able to bring children. So I have only one daughter, because I had a problem with my reproductive system. That's why I was able only to give one child. Okay, and it's not a reason for us not to say if our marriage, the good age for marriage is 26 and above. Okay, and then you have to plan your marriage before you hop into it. Even you know what, in every one of us, we don't have to be in a hurry, because you know what, our creator, the moment we were born, he already has one man for each one of us, and that will be given to us in his time, and we don't have to be in a hurry for that. Okay, so how old are the midwifery students now? I think you are 21, 18, 19, 20, like that.
Yes.
Yeah, okay. So you are still in the early years. So I hope you try to plan your marriage. Okay, you don't plunge into it right away. You have to take you have to think of it, as I've mentioned a while ago, 100 times before you go into marriage. Is this the guy that will really love me? Is this the guy that will be my partner in life? As I mentioned a while ago in the 3 goods of marriage, will he be the one to be in fidelity?
Okay, he will not look for other women along the way when we have our family. Okay, this is the problem. What happens is men will go into like look at other women, and that's the start of the now the problem of husband and wife. They quarrel because of that, and later on women should try to take care of their husband so that they will not get out of their way. So that's the secret of that. Okay, so plan your marriages. Do not go into it just you have all the time. Okay, you have all the time, and as I've mentioned, God, your creator, has chose one man for you. Okay, even though you say, oh, the ratio, the female ratio to male ratio is there are a lot of female. No, God has ways to do that. Okay, did I answer the question?
Excuse me for...
Yeah, planning for a good and best marriage. Okay.
Yes. I'm sorry, Mrs. Curly Jordan. This is one more questions for our lecturer.
Okay.
Mrs. Henny. In our place, the number of early marriage is still high, especially in the villages, and some of the reasons for this are cultural. How about in the Philippines? What form of women's empowerment are carried out by midwives to overcome the problem of early marriage? How to develop their critical thinking skills and increase their awareness of reproductive rights? How about empowering in youth?
Okay. Okay, that's a very good question. Now, in the Philippines, we have programs, as I've mentioned, population commission. So there is, in the villages, we have also what villages, we call it the rural health units, puskesmas. What we call your puskesmas. We have puskesmas to take charge of that. So the midwife, they have their own barangay to take care of. They have their own puskesmas to handle. So they go from house to house. Okay, so they will, the families will visit the puskesmas, or the midwives will go around and look at the families and then see. So how can we stop these early marriages? So children must go to school. Okay, free from the we have in the government sector, the education is free for children. Okay, so it's free. In the private sector, maybe parents will bring their children to private sector, like in St. Paul University, Philippines, but it's expensive. But for those who cannot afford to bring their children in a private school, they can bring them to the government school, and it's free. Okay, in the college, the tuition fee is minimal. And this is to encourage the children to go to school and not to be staying there only in the village and then not doing nothing, and then later on they will just get married at any time. So we encourage them to go to school, finish a degree, okay, and then the midwife always go there and check the family, okay, and then give health education. They also invite them to come over and then attend to, when it's we will still have the face-to-face. They invite these teenagers to a place wherein they give maybe videos about this regarding the early marriages and what will happen to them. So they will be having an insight that if they do marry earlier, then that this will happen to them. So they will show them a film, a video regarding a case of an early marriage and what will happen to these women. So after that, they will be asked for some reflections and insights about the video that they have learned. And then the midwife will process the reflections of these children or these teenagers on the video that was presented to them. Okay. And the parents also are given lectures to take care of their children, the female children, of what to do so that they will not be able to go astray or to get married as early as possible. Okay, so there are many programs in the Philippines that we have, not only in the population commission, we have in the puskesmas, because midwives are assigned in every barangay, we call it barangay. Okay, or any every rural health unit, and this midwife will take care of that particular barangay. Okay, that the children, the women children or the girls are not being left
alone, and they are being taught how to they have to attend classes, they have to go to school and to finish a degree. Okay, you know what, in the Philippines it's now the opposite of it. The women now, the girls are now the ones who are very interested to go to school, and the boys now are the ones disinterested. So what happens to these boys? They work in the farm, they work in the factories, but these girls or these women are now the ones who reach a higher degree, and they work in offices, they work in companies, okay, they work in hospitals, okay, they work in institutions that require a bigger degree, higher degree that they were able to get. Okay, so women here are really empowered. Okay, and especially in the medical courses, women, you can see all the women in the medical courses, a few only of the men.
Okay.
Okay.
Okay. Thank you, ma'am, because the time is limited. And well, all of the questions have been answered properly and wisely. I think there is an enthusiasm atmosphere here because many questions have been delivered. And I hope the participants are satisfied with the insights that are given, and hopefully the knowledge that provided is useful. And the last in here, I will deliver simple notes that women empowerment is an effort to bring up the ability of women to express themselves and make decisions in accordance with their right as human beings. But in addition, the principle of women empowerment is to realize equal rights between men and women in various fields. For example, freedom from violence and threat, access to the health, opinion, politics, the public, making decisions, and all things that should be right for human being as a living beings. And thank you, ma'am. Thank you for all of participants. That's the end of this session. Thank you very much to Mrs. Curly Jordan as the presenter of this session for the precious knowledge, and thanks to participants for the questions that have been submitted. Please give applause to our presenter.
You are most welcome. Yeah, thank you also. Okay, I'll be looking forward to working with you again.
Yes.
Okay.
And dear Ma'am Curly Jordan, if you have another agendas after this, you can leave this forum. But if you have free time, then we are very grateful if you follow this event until the end. So I return the time to Master of Ceremony and enjoy the next conference. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you too.
Thank you to Hafidatul Ilmiah Parera. Participants, please kindly turn your camera on and mute your microphone. Listen mindfully and feel free to ask questions. Last but not least, we will enter the third speaker, delivering Kuliah Tamu material with such an interesting sign language in midwifery care for mothers with special needs, which will be led by Anissa Sudipyo as moderator. Anissa Sudipyo adalah seorang mahasiswi program studi D3 Kebidanan Malang. Dan saat ini beliau tergabung dalam tim aksi cepat tanggap Madiun. For Anissa Sudipyo, please, time is yours.
Okay, thanks to the Master of Ceremony, I will host in Bahasa. Oke, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera bagi kita semua. Izinkan saya memperkenalkan diri. Nama saya Anissa Sudipyo sebagai moderator pada narasumber ketiga kita hari ini. Nah, setelah dari awal tadi pakai English gitu ya, sekarang saya akan membawakan acaranya dalam bahasa Indonesia. Sebelumnya saya akan membacakan peraturannya terlebih dahulu, yaitu hanya narasumber yang dipersilahkan berbicara saat memberikan paparan materi. Untuk yang lainnya dimohon untuk menonaktifkan mikrofon. Dalam sesi pemaparan materi oleh narasumber, waktu yang diberikan adalah 45 menit, dan pada 5 menit terakhir saya akan ingatkan kembali. Selanjutnya adalah sesi diskusi atau tanya jawab yang berlangsung selama 15 menit. Selama pemaparan materi maupun diskusi, peserta dipersilahkan mengajukan pertanyaan dengan menulis pada kolom chat Zoom atau di kolom komentar YouTube untuk yang live streaming. Dengan format nama, jurusan atau instansi, ditujukan kepada siapa pertanyaannya, setelah itu baru pertanyaannya. Dan pertanyaannya akan dipilih oleh panitia untuk dijawab oleh pemateri. Nah, pada kesempatan kali ini kita kedatangan narasumber yang luar biasa yang akan berbagi ilmu yang tentunya sangat menarik dan juga sangat ditunggu-tunggu. Dengan judul Bahasa Isyarat dalam Asuhan Kebidanan bagi Ibu Berkebutuhan Khusus oleh narasumber ketiga kita, Ibu Firly Imaniar SPD dari Yayasan Putra Pancasila. Berikut saya akan bacakan CV-nya. Ibu Firly Imaniar, lahir di Malang, 13 April 1997. Pengalaman organisasi, dua yang terakhir adalah sebagai pemateri kelas Bahasa Isyarat BMFHUB 2020, penerjemah isyarat pada pelatihan yang diselenggarakan Dinas Sosial. Riwayat pendidikannya adalah Universitas Negeri Malang. Sarjana Pendidikan Luar Biasa tahun 2016. Selanjutnya kita akan sapa narasumber ketiga kita. Selamat siang Ibu Firly, bagaimana kabarnya?
Alhamdulillah baik. Selamat siang semuanya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Baik, kepada Ibu Firly Imaniar SPD, saya persilahkan untuk memulai penyampaian materi dengan judul Bahasa Isyarat dalam Asuhan Kebidanan bagi Ibu Berkebutuhan Khusus.
Terima kasih. PPT-nya mungkin bisa di-share, Mbak. Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, nama saya Firly Imaniar. Dalam kesempatan kali ini, saya akan menjelaskan tentang bahasa isyarat dalam asuhan kebidanan bagi ibu berkebutuhan khusus. Berkebutuhan khusus di sini satu ya, berkebutuhan khusus tunarungu atau tuli yang menggunakan bahasa isyarat. Oke, next. Apakah bahasa isyarat itu? Jadi, bahasa isyarat merupakan bahasa yang digunakan untuk berkomunikasi dengan gerakan bibir dan bahasa tubuh, termasuk ekspresi wajah, pandangan mata, dan gerak tubuh. Jadi, bahasa isyarat ini kompleks ya. Jadi, bisa kita pelajari dengan ekspresi wajah, gerak bibir, ataupun dalam bahasa tubuh atau yang kita namakan bahasa isyarat. Next. Selanjutnya, oke. Berikutnya yaitu cara berkomunikasi dengan tunarungu atau tuli. Karena tunarungu ini memiliki karakteristik yang cenderung egois dan cenderung merasa dirinya diomongkan gitu. Jadi kalau tunarungu ada di masyarakat luas itu, mereka akan sedikit minder dengan kenapa sih orang-orang itu berbicara dan menghadap saya. Apakah mereka semua menertawakan saya dengan kekurangan saya ini? Jadi tunarungu itu lebih bersifat kecil hati gitu ya. Jadi cara berkomunikasinya yang pertama yaitu keterarawajahan. Jadi tunarungu dan orang yang ingin berbicara dengan tunarungu harus melihat dengan dekat ya, harus berhadapan dan harus kontak matanya itu harus apa ya, harus melihat gitu. Jadi tidak bisa kita berbicara dengan tunarungu tapi kita seakan-akan menoleh ke kanan, ke kiri, itu tunarungu akan tidak bisa mengetahui apa yang kita maksud. Yang kedua yaitu bicara harus jelas dengan ucapan yang benar. Tunarungu tidak suka dengan lawan bicara yang biasanya kan ada yang tunarungu, ada yang berbicara dengan tunarungu menggunakan oral yang lebih seperti A, B, C gitu, itu tunarungu tidak suka. Jadi tunarungu itu masih bisa melihat gerakan bibir kita yang seperti biasa ini. Jadi tidak perlu kita A, B, C, gimana caranya, yang menggunakan oral yang terbuka lebar itu tunarungu biasanya tidak suka dan cenderung kenapa sih mereka kok bicara dengan saya seperti ini, padahal bicara dengan orang lain biasa saja. Karena tunarungu bisa dengan sendirinya membaca oral kita yang seperti biasa ini. Yang ketiga yaitu gunakan kalimat sederhana dan singkat. Jadi tunarungu juga tidak bisa untuk pertanyaan atau diskusi yang bertele-tele. Jadi harus to the point gitu. Jadi kalau misalnya contohnya ibu baru pertama kali ke sini ya, kira-kira ibu mau apa gitu. Itu tunarungu sangat kebingungan nantinya akan pertanyaan seperti itu. Jadi lebih baik disederhanakan saja pertanyaannya, bisa dengan contoh, ibu ke sini mau apa? Itu bisa. Yang keempat yaitu gunakan komunikasi nonverbal seperti gerak bibir atau gerak tangan. Yang gerak tangan ini seperti bahasa isyarat ya, bahasa isyarat, dan gerak bibir seperti yang oral tadi. Yang kelima yaitu gunakan ucapan yang jelas dan volume suara tidak perlu dibesarkan. Jadi banyak orang yang menggunakan volume sedikit keras untuk berbicara dengan tunarungu. Sebenarnya ini tidak diperlukan ya, karena tunarungu itu kan pada dasarnya tidak bisa mendengar. Jadi kalau volume suara dibesarkan pun mereka juga tidak akan bisa mendengar. Jadi percuma itu. Yang harus diingat yaitu gunakan ucapan yang jelas. Jadi ucapan yang tadi seperti tadi bahasa oralnya itu harus jelas. Tidak perlu seperti bahasa oral yang harus mulutnya terbuka lebar, itu tidak bisa, tidak perlu gitu ya. Jadi cara berhubungan komunikasi dengan tunarungu itu yang pertama gunakan bahasa yang singkat. Jadi bahasa yang singkat, pertanyaan yang singkat, jelas. Kemudian gunakan kata kunci, misalnya ibu hamil anak keberapa gitu. Ini hamil pertama atau keberapa, jadi bisa dengan cara itu. Karena tunarungu hamil keberapa itu sedikit kebingungan ya, karena kan tunarungu komunikasinya kan SPOK-nya itu tidak seperti SPOK seperti kita yang dapat berbicara dengan normal. Oke, next, selanjutnya. Ya, selanjutnya kita akan belajar bahasa isyarat yang huruf ya. Jadi pada dasarnya sekarang kan ada peraturan untuk menyetarakan di layanan publik. Jadi harus ada yang menangani bahasa isyarat ini, menangani teman-teman berkebutuhan khususnya tuli agar bisa berkomunikasi dengan kita dengan lancar. Jadi tidak tersendat-sendat gitu ya. Jadi di sini ada abjad yang bisa digunakan untuk pembelajaran pertama gitu. Pembelajaran pertama pada cara berkomunikasi dengan tunarungu. Di sini saya akan mempraktekkan ya huruf-huruf abjad. Kalau di gambar mungkin tidak terlalu jelas dan mungkin hanya gambar, jadi kita praktekkan secara bersama-sama. Jadi di sini ada huruf A. Huruf A adalah tangan menggenggam, tapi jempolnya ada di ujung di sini. A. Kelihatan ya. B, seperti angka 4, jempol menghadap ke sini. C, D seperti menunjuk satu gini ya, tapi ininya lingkaran. D, E seperti mencengkram. E, F, G seperti ingin mencubit. H, I, J seperti I tapi memutar. J, K, tangan 2, kemudian jempol disisipkan di antara kedua jari tengah dan jari telunjuk. K, L, M, jadi 3 lalu dijepitkan. Jadi jempol masih kelihatan di sini. M, N, 2 dan jempol juga disisipkan di sebelah sini. N, O, P. Jadi kalau K seperti ini ke atas, kalau P hadap ke samping. P, Q, R, S. Jadi kalau di samping, jempolnya di samping ini huruf A, kalau jempolnya di tengah ini huruf S. S, T, 2 jari telunjuk dan jari jempol, T, U, 2, U, F, tinggal kita buka, F, W, 3 angka, W, X, Y, dan Z. Seperti itu ya. Ini nanti bisa di screenshot, bisa untuk belajar di rumah, sehingga nanti kalau terjun ke lapangan dan menemui kasus ibu hamil yang berkebutuhan khususnya tunarungu, bisa digunakan dalam berbahasa atau dalam berkomunikasinya. Lanjut, next. Yang next ini ada kata tanya dalam bahasa isyarat. Kan di dalam kebidanan kita kan harus aktif menanyakan apa keluhan ibu, apa masalah ibu kesini untuk kontrol apa, kan seperti itu. Jadi kita harus tahu kata tanya dalam bahasa isyaratnya. Jadi kita harus menemukan kata kuncinya gitu. Jadi kalau bagaimana keadaan ibu saat ini, atau mengapa ibu ke sini, ada keluhan apa, siapa yang mengantarkan ibu, apa yang membuat ibu ke sini, terus kapan misalnya haid terakhir, terus berapa jumlah anak ibu, gitu kan. Jadi kalau bagaimana, jadi tangan 2, tangan dari atas ke sini, ke depan dada, dan digoyangkan ke depan dan ke belakang secara bergantian. Bagaimana? Kemudian mengapa? Jadi di kepala, di kening, lalu dihadapkan ke depan dada. Mengapa? Misalnya, mengapa ibu ke sini? Tuh, siapa? Jempol, lalu dihadapkan di dagu. Siapa? Siapa yang mengantar ibu ke sini? Contohnya gitu. Apa seperti bagaimana. Cuma kalau bagaimana tadi kan dari atas sini bagaimana. Kalau apa langsung dari dada. Jadi kalau bagaimana dari atas sini, bagaimana kalau apa langsung dari sini. Apa keluhan ibu contohnya. Terus kapan huruf K lalu digoyang-goyangkan di depan dada ke samping kiri dan ke kanan. Kapan? Terus berapa? Gini aja. Berapa? Jadi seperti berhitung. Berapa gitu. Oke, next. Jadi di sini kemarin saya dikasih contekannya ya. Jadi ada di ruang administrasinya sama saat pemeriksaannya. Jadi mungkin nanti kalau sudah terjun ke lapangan dan menemui ibu hamil khususnya tunarungu akan mengalami kesulitan untuk berkomunikasi atau bagaimana sih kalau saya sudah hafal dengan huruf-huruf, tapi kalau ngeja huruf satu-satu itu terlalu lama dan sulit untuk menghafalnya gitu. Jadi kita akan mencontohkan contoh pertanyaan atau contoh pertanyaan saat ibu bidan ingin bertanya kepada tunarungu atau next. Jadi di sini kan administrasi untuk menanyakan alasan data, mengisi registrasi sesuai tempat pelayanan KIA. Oke, lanjut. Di sini akan saya contohkan ya dalam bahasa isyaratnya, bisa direkam atau bisa diingat-ingat nanti. Jadi yang pertamanya kan menanyakan keperluan kedatangan ibu ke tempat pelayanan KIA. Jadi untuk apa sih ibu datang ke sini? Apakah untuk memeriksa kehamilan atau ingin alasan lain gitu kan? Jadi bisa kalau kita berkomunikasi dengan orang normal ya, itu kan penataan bahasanya kan kita nggak usah mikir gitu. Maksudnya seperti ngapain ke sini gitu. Ibu datang ke sini apakah ingin periksa kehamilan atau ingin berkonsultasi atau apa. Kalau tunarungu ini kan sedikit membingungkan ya. Jadi yang poin pertama tadi kan harus to the point. Jadi ngomongnya harus secara singkat dan jelas dan gunakan kata kuncinya. Gitu. Jadi yang pertama mungkin bisa untuk apa ibu datang? Apakah periksa kehamilan? Jadi bahasa isyaratnya seperti ini. Untuk apa ibu ke sini? Datang ke sini. Apakah periksa kehamilan? Satu kali lagi ya. Untuk apa ibu datang ke sini? Apakah untuk periksa kehamilan? Kalau misal jawabannya iya, betul, saya ingin periksa kehamilan. Jadi mungkin bisa disilakan duduk atau mungkin kalau bukan periksa kehamilan, contohnya jawabannya saya sakit perut tapi tidak tahu hamil atau tidak. Kita bisa melakukan pelayanan yang sesuai dengan jawaban si ibu ini. Kemudian yaitu menanyakan kunjungan pemeriksaan yang pertama atau kunjungan berulang. Jadi kan ini penting ya, kalau pertama itu biasanya kan kita disuruh mengisi administrasi seperti nama ini nanti akan diberikan buku KIA-nya. Kalau yang sudah lama kan kita lihat catatan di buku KIA-nya. Jadi yang bisa kita gunakan dalam bertanya atau berkomunikasi dengan tunarungu yaitu apakah baru ini periksa atau dulu sudah periksa. Kalau mungkin orang normal biasanya ibu ini periksanya baru pertama ini atau sudah pernah periksa gitu. Kalau tunarungu itu kan bahasanya sedikit terbolak-balik ya. Jadi kita juga harus menekankan kata kuncinya. Jadi misalnya bisa dengan apakah baru ini periksa atau dulu sudah periksa. Bisa dengan itu. Misalnya, saya baru di sini baru periksa karena saya nggak tahu saya hamil atau tidak. Misalnya jawabannya seperti itu. Kemudian, saya ulangi lagi ya. Apakah baru ini periksa atau dulu sudah periksa? Misal jawabannya, saya baru ini periksa. Tuh. Kemudian, atau jawabannya mungkin, saya dulu sudah periksa, tapi di dokter lain, misalnya gitu. Kemudian yang kedua, periksa pertama, kita akan harus menjelaskan, jika ini pemeriksaan pertama, maka pemeriksaan ini akan membutuhkan sedikit waktu yang lebih lama. Jadi bisa periksa pertama ini, bidan harus periksa lebih dan tanya jawab. Jadi waktu sedikit lama. Kita ulangi ya. Periksa pertama, bidan harus periksa dan tanya jawab, jadi waktu sedikit lama. Kita harus menjelaskan kenapa kok waktu kita daripada orang-orang yang sebelumnya ini waktunya lama, karena ini pemeriksaan yang pertama. Jadi biasanya kan kalau pemeriksaan pertama kan sedikit ditanya-tanyai banyak hal gitu ya. Kemudian yang misalnya ini pemeriksaan pertama, bidan kan juga memberikan buku KIA dan menjelaskan bahwa buku KIA-nya ini tidak boleh hilang karena ini dipakai sampai anak usia 5 tahun gitu. Jadi kita harus menekankan buku ini tidak boleh hilang dan harus disimpan sampai umur anak 5 tahun gitu. Jadi kita bisa bilang seperti ini ya, atau bahasa isyaratnya seperti ini. Ini buku KIA, ini harus disimpan dengan baik, tidak boleh hilang. Buku ini untuk anak sampai usia 5 tahun. Jadi tidak boleh hilang. Jadi harus ditekankan ya, bahwa buku ini harus disimpan dan buku ini tidak boleh hilang. Intinya seperti itu, agar si ibu yang mengalami berkebutuhan khusus ini juga menyadari, mengetahui bahwa buku ini harus disimpan. Jadi tekankan, nggak apa-apa bilang ini disimpan, mengulangi kata-katanya itu nggak apa-apa. Tapi mungkin cuma orang tunarungu itu jadi merasa tersinggung kalau kita menulis di kertas gitu. Ini tidak boleh hilang, ini. Mereka akan merasa seperti kamu bukan temanku, aku tidak akan mau datang ke sini lagi gitu. Jadi tunarungu itu lebih baiknya memang menggunakan oral atau bahasa isyarat. Jadi kalau biasanya akan mudah tersinggung ya kalau kita menuliskan sesuatu, misalnya menuliskan ibu sakit apa, terus kemudian ibu si tunarungunya itu menuliskan saya hamil ini, itu merasa agak sedikit saya bisa kok berbicara, saya bisa kok berbahasa, saya bisa kok berkomunikasi, kenapa harus menulis gitu. Jadi mungkin tunarungu itu sifatnya kan egois itu. Kemudian kalau mungkin pemeriksaan berulang, kan biasanya kan sudah punya buku KIA. Kita menanyakan apakah buku KIA-nya dibawa gitu untuk memeriksa kontrol keberapa ini gitu kan. Jadi misalnya sudah ada buku KIA, apa sekarang dibawa? Misal dibawa, oh iya ini, biasanya mereka akan mengambil dan menunjukkan ini bukunya, boleh pinjam gitu, boleh pinjam gitu. Kemudian menuliskan biodata ibu dan pasangan dengan jelas. Ini kan perlu untuk mengisi di buku KIA-nya itu ya. Jadi tunarungu memang tidak suka berkomunikasi dengan cara menulis. Tapi kalau misalkan di situ ada nama, alamat, umur, tanggal lahir, tempat tanggal lahir, suaminya siapa, gitu itu pasti dia akan bisa paham gitu. Alamatnya misalnya ditulis alamatnya Jalan Ijen gitu, Jalan Ijen RT berapa, RW berapa, kita harus menekankan, kita bisa menuliskan RT, kosongi saja, terus RW berapa, kecamatan, kelurahan, nanti mereka akan bisa mengisi dengan sendirinya, atau bisa mereka lihat di KTP. Kalau itu saya rasa semua tunarungu bisa paham ya untuk alamat, nama suami, umur, nama, dan lain-lainnya itu. Kemudian next. Ini saat pemeriksaan. Di saat pemeriksaan ini kan bidan lebih banyak bertanya ya, lebih banyak bertanya kepada ibu. Jadi mungkin ini lebih sedikit banyak. Next. Jadi pemeriksaannya yang pertama kan silakan duduk ibu gitu. Menanyakan keluhan yang dirasakan. Apa keluhannya? Biasanya kan kalau orang normal kan ibu mengalami keluhan apa? Keluhan seperti apa yang ibu rasakan? Kalau tunarungu itu langsung to the point aja. Apa keluhan atau pemeriksaan sekarang ibu ini? Apa keluhan atau sakit ibu kemarin gitu. Bisa kan kalau keluhan itu nggak harus pas hari ini ya, biasanya kan satu bulan itu keluhannya apa saja gitu. Jadi apa keluhan ibu kemarin selama 1 bulan gitu. Atau sejak kapan ibu merasakan keluhan ini, misalnya saya pusing atau saya sering muntah, gimana ya caranya gitu. Atau badan saya kemudian sejak kapan ibu mengalami keluhan ini? Atau bisa kita misalnya kan saya sering muntah-muntah dok gitu. Jadi kapan ibu rasakan keluhan ini? Misalnya gitu. Atau bisa juga dengan dari kapan ibu muntah-muntah, misalnya keluhannya muntah-muntah gitu. Atau kapan ibu merasa pusing, misalnya malam hari atau pagi hari, atau setiap saat saya merasa pusing gitu. Setiap hari saya pusing, atau malam hari saya pusing, atau bisa pagi hari saya pusing gitu. Kita bisa melakukan tindakan yang lainnya. Kemudian menanyakan riwayat menstruasi. Jadi tunarungu itu tidak mengetahui ya apa itu mens itu. Jadi mereka kan karena bahasanya yang sederhana, jadi datang bulan itu bisa kita singkat saja M gitu, mens gitu. Jadi mereka akan pahamnya jika datang bulan itu mens gitu. Jadi bisa ibu tanyakan, bisa bidan tanyakan kan biasanya kapan pertama mens dan kapan hari terakhir mens. Jadi kita untuk menghitung masa suburnya gitu kan, atau menghitung apa gitu. Jadi tanggal atau tanggal berapa ibu mulai mens M gitu aja. M. Kalau datang bulan, bahasa isyaratnya gini ya, datang bulan. Jadi datang bulan itu apa? Tunarungu akan mengalami kesulitan karena bahasa sehari-hari yang digunakan adalah mens gitu. Jadi bisa kita tanyakan tanggal berapa, langsung berapa. Tanggal berapa ibu mulai mens, sampai tanggal berapa ibu mens gitu. Kalau misalnya saya mens tanggal 28 misalnya gitu, tanggal 28. Bulan apa? Bulan apa? Bulan kemarin atau bulan ini, bisa jadi. Kemudian menanyakan tentang kehamilannya yang sekarang. Misalnya ibu sudah punya anak sebelumnya atau belum, atau ibu ini kelahiran mengandung pertama atau keberapa gitu kan. Biasanya kita ditanya seperti itu. Jadi kita bisa bertanya dengan bahasa isyarat, sekarang hamil keberapa? Sekarang hamil ke berapa? Sekarang hamil ke berapa? Misalnya, oh saya ini masih pertama, atau ini sudah kedua, ini sudah ketiga, dan seterusnya. Kemudian sudah tes kehamilan, kalau biasanya kita kan dengan orang normal sudah menggunakan tes kehamilan, kalau di bawah apakah saya boleh lihat atau enggak, misalnya enggak di bawah gitu. Jadi bisa kita gunakan kalau tes spek ini tunarungu sedikit kesulitan ya, apa itu tes spek. Jadi kita bisa mencontohkan dengan seperti ini. Ini tes spek, isyaratnya tes spek gitu. Kalau ditulis tes spek, nanti tunarungu akan kesulitan. Apa tes spek apa ya? Tes spek itu apa ya? Tes kehamilan itu, mereka tidak akan paham tentang itu. Jadi yang bisa diisyaratkan, sudah gunakan tes spek. Kalau iya, boleh saya lihat gitu. Misalnya, oh di rumah dok, di rumah saya nggak bawa gitu. Oh nggak apa-apa, nanti kan mungkin bisa dilakukan pemeriksaan yang lainnya. Atau kalau bawa, oh ya ini bawa, nanti dia akan langsung mengasihkan tes speknya itu ke ibu bidan. Terus kemudian kalau pemeriksaannya sudah berulang, sudah berapa kali periksa di mana, dengan dokter siapa, seperti itu kan biasanya pertanyaan dengan yang orang normalnya. Kemudian kalau tunarungu itu bisa kita singkat saja, jadi sudah berapa kali periksa, atau sudah kamu, misalnya ya, kamu sudah periksa dulu, sudah periksa gitu. Misalnya, saya sudah periksa dulu, tapi sudah lama, misalnya seperti itu. Atau saya baru periksa ini, baru pertama, misalnya gitu. Kemudian jika iya, jawabannya iya, di mana dan dokter siapa gitu. Di mana dokter siapa, misalnya. Oh, saya lupa namanya, tapi di RSA gitu misalnya, di RSB atau RSC gitu. Oh ya, nanti kan kita lihat buku KIA-nya, kita cocokkan dengan datanya. Kemudian kemarin jika sudah periksa, kemarin sudah diberi obat, Bu. Bagaimana Ibu meminumnya? Apakah teratur atau bagaimana? Terus rasanya yang dirasakan setelah minum obat itu seperti apa? Kalau orang normal biasanya kan ditanya seperti itu. Kalau tunarungu itu tidak bisa kita tanya secara pertanyaan yang panjang gitu. Jadi harus sedikit-sedikit, pokoknya dia paham, baru dia akan mengerti gitu. Tekankan saja kata kuncinya. Misalnya, kemarin sudah diberi obat. Kemarin sudah diberi obat, misalnya gitu. Terus kemarin sudah diberi obat banyak, biasanya kan gitu tunarungu, atau belum, kemarin belum dikasih obat gitu. Terus kita tanya lagi, bagaimana Ibu minumnya, minum obat, apakah lancar atau gimana, misalnya gitu. Ibu minum obat rajin atau malas, bisa seperti itu ya. Misalnya, oh saya enggak suka minum obat karena rasanya pahit, jadi saya enggak suka, misalnya gitu. Kemudian kalau misalnya, oh iya ini masalah obat sudah selesai, ini dikasih resep dan lain-lain, terus bidan akan bertanya lagi, sudah bisa hitung gerakan bayinya, Bu? Kira-kira dalam 1 jam berapa ya gerakan bayinya? Atau kapan pertama Ibu merasakan gerakan bayinya? Kapan terakhir? Tuh. Apakah Ibu pernah menghitung dalam 1 jam itu gerakan bayinya berapa? Misalnya seperti itu kalau kita bertanya ke orang normal. Jadi kalau tunarungu tuh kita pendek-pendek saja, bertanyanya pendek-pendek saja, kemudian beliau jawab, kita tanya lagi, beliau jawab, kita tanya lagi. Jadi tunarungu tuh nggak bisa kalau kita tanyai langsung satu pertanyaan langsung non-stop gitu, nggak bisa. Jadi harus satu-satu. Jadi misalnya sudah bisa hitung gerak bayi atau mungkin janin ya. Kalau tunarungu itu janin nggak tahu. Kalau bayi yang di dalam perut itu berarti sedang hamil. Kalau bayi saat sudah dilahirkan itu biasanya isyaratnya beda. Jadi kalau bayi di dalam perut itu langsung kita perut gitu. Kalau bayi yang sudah dilahirkan atau bayi yang sudah dilahirkan itu gini, bayi biasa bayi. Misalnya sudah bisa hitung gerak bayi di perut, misalnya gitu, di perut, gerak perut gitu. Terus kapan pertama kali Ibu rasakan bayi bergerak? Seperti itu. Kapan pertama Ibu rasakan bayi bergerak? Tuh, kemudian kapan terakhir Ibu rasakan bayi bergerak? Jadi sama aja ya, kalau pertama gini, kalau terakhir seperti ini. Terus kita bisa, Ibu pernah hitung gerak bayi di dalam perutnya, Bu? Biasanya dalam 1 jam kira-kira berapa? Dokter akan misalnya bertanya seperti itu. Jadi kita bisa menggunakan bahasa isyarat. Ibu pernah, Ibu sudah atau selesai itu sama. Ibu pernah hitung gerak bayi di dalam perut, langsung bayi di dalam perut gitu. Kalau bayi di dalam perut nanti mereka akan kebingungan juga ya. Jadi langsung to the point saja. Ibu pernah hitung gerakan bayi di dalam perut, misalnya seperti itu. Oh, saya enggak pernah hitung. Tapi saya rasakan ada yang bergerak, misalnya seperti itu. Atau mungkin kalau ibunya menghitung, ya, iya dok, saya hitung misalnya 15 kali dalam 1 jam, gitu, misalnya seperti itu. Kemudian, apakah keluhan ibu ini ada yang kayak ibu pernah mengalami muta yang hebat, terus sakit perut, keluar darah seperti mem, demam, pusing, tekanan darah tinggi, pandangan buram dan sebagainya. Itu kan seperti apa ya? Kalau panjang gini tunarungu nggak akan paham ya. Jadi satu-satu aja bisa ditulis. Ini bisa kalau yang poin-poin ini bisa ditulis dan ibu bisa memilih, oh ini muta yang hebat itu apa ya, muta yang sakit itu apa ya. Kalau kita kan kalau menamakan itu kan muta yang hebat atau muta yang misalnya setiap pagi gitu. Jadi kalau tunarungu itu bisa kita mutah yang sakit gitu. Muta yang sakit itu biasanya muta tapi biasa atau muta yang sakit, atau misalnya sakit perut yang seperti kram gitu. Sakit perut yang sakit, pokoknya yang sakit gitu. Biasanya tunarungu itu antara sakit biasa, sakit sedengan sama sakit nganu itu berbeda bahasa isyaratnya. Jadi misalnya sakit, misalnya kenapa kamu nggak masuk, aku sakit perut gitu. Kalau sakit yang misalnya level 2 itu aku sakit perut kemarin, sakit sekali gitu. Atau kalau yang ketiga, saya sakit perut kemarin, periksa katanya apa gitu. Atau ini di perut saya ada yang apa gitu. Biasanya tunarungu itu mengisyaratkan dengan apa yang dialami. Jadi kan mereka tidak mengetahui misalnya ini sakit perut kram, ini sakit perut diare, ini sakit perut apa. Mereka nggak akan mengetahui ini macam-macamnya sakit perut gitu. Jadi ini sakit perut seperti apa misalnya gitu. Sakit perut di sini seperti ada yang nendang-nendang biasanya gitu mereka kalau membahasakannya gitu. Terus biasanya kalau kita pendarahan, apakah pendarahan kalau dalam bahasa dengan ibu normal itu pendarahan, kalau tunarungu nggak bisa pendarahan itu apa, apakah keluar darah dari mana, apakah dari tangan sudah dianggap pendarahan atau dari kaki jatuh itu dianggap pendarahan gitu. Jadi kita bisa mengisyaratkan dengan keluar darah seperti M. Jadi kan kalau seperti M jelas itu keluar darahnya dari mana gitu. Jadi keluar darah seperti M. Tuh. Keluar darah seperti M. Tuh. Atau demam, pusing, darah tinggi atau tekanan darah, mata buram, nggak bisa lihat biasanya gitu. Aku pusing, biasanya saya temui seperti ini ya. Saya pusing, mata nggak bisa lihat, sampai mata nggak bisa lihat biasanya gitu. Atau mungkin kejang, kalau kejang itu kita praktekkan ya, kejang gitu. Atau wajah dan tangan yang bengkak, atau wajah dan tangan bengkak, atau wajah bengkak, tangan bengkak, sakit biasanya gitu. Atau bayi di dalam perut tidak bergerak. Kemarin saya sudah bisa rasakan perutku bergerak, tapi sekarang nggak bisa. Gimana? Misalnya nanti pertanyaannya akan seperti itu. Kalau tunarungu biasanya akan lebih singkat gitu pertanyaannya. Atau mungkin kalau tunarungu yang cerewet ya, mungkin yang cerewet itu nanti akan diceritakan mulainya dari pertamanya dia sakit sampai terakhirnya. Jadi saya pernah menemui ya, saya bukan dokter, tapi saya aktif di dalam kegiatan sosial. Jadi kalau tunarungu sakit pasti dinsos itu pasti akan menjenguk gitu ya, menjenguk dan menanyakan apa ininya sakitnya apa. Jadi kalau yang ketemu yang cerewet itu dia akan senang berbicara kayak saya kemarin hamil, pertamanya saya jatuh waktu kecil, lalu kemudian ini nanti akan diceritakan prosesnya itu. Itu kalau tunarungu yang cerewet. Tunarungu juga bisa cerewet kalau dia menemukan lawan bicara yang nyambung atau yang ini dia bisa mendengarkan cerita saya, atau dia misalnya dia nggak bisa mendengarkan cerita saya, jadi saya percuma bercerita. Seperti itu. Jadi kalau misalnya di dalam dunia kebidanan juga nanti mungkin bisa, kalau misalnya bidannya mengerti dengan bahasa tunarungu, maka kan akan terjadi komunikasi yang aktif. Jadi dari bidannya dan dari pasiennya ini nanti akan menemukan kecocokan. Jadi misalnya kalau tunarungu itu gini ya, saya sudah cocok dari dokter satu ini, misalnya gitu. Jadi nanti mereka akan berbicara ke teman-temannya. Ini dokter ini bisa bahasa isyarat, dokter ini bisa tahu kalian sakit apa, bisa sembuh dengan cepat atau gini. Mereka paham dengan apa yang kamu katakan. Biasanya mereka akan seperti itu. Jadi tunarungu itu juga apa ya? Biasanya tunarungu itu mempunyai komunitas. Komunitasnya itu jadi sedikit banyak yang mereka alami, mereka akan share ke teman-temannya yang sesama tunarungu itu. Kemudian next. Kemudian di sini ada menanyakan riwayat obstetrik. Jadi misalnya kalau ini kehamilan yang berulang, waktu hamil anak pertama pernah muntah, sakit seperti emeng dan yang lain-lain itu, atau di anak kedua ini saja ibu merasakan seperti ini gitu. Jadi kita bisa bertanya dengan sama tadi, diulangi lagi, kemarin hamil pertama ibu pernah muntah misalnya, atau anak pertama, anak ketiga, anak keempat, misalnya sekarang mengandung anak ketiga, jadi kita tanyanya kemarin hamil anak 1 dan 2 ibu muntah yang sakit gitu, atau perut sakit, itu kita ulangi lagi dalam bahasa isyaratnya itu, misalnya pendarahan, atau kita bisa membahasakannya keluar darah seperti M gitu, demam, pusing, tekanan darah tinggi dan lain-lain. Ini nanti kalau misalnya yang poin-poin ini kan lebih penting gitu. Ini bisa ibu bidan mengelis kemudian mereka suruh mencontek, misalnya kalau ini iya dicontreng gitu. Kalau enggak dok, saya dulu hamil dulu enggak seperti ini, baru ini anak kedua, atau hamil kedua saya muntah hebat, atau misalnya saya keluar darah seperti M, misalnya seperti itu. Kemudian kita tanyakan dulu waktu hamil anak, waktu melahirkan anak pertama, kedua, dan seterusnya, itu dokternya siapa? Melahirkannya dengan proses normal atau sesar, misalnya gitu. Kalau sesar, mungkin tunarungu nggak akan paham ya sesar itu apa, jadi misalnya bisa diganti dengan kata kerja operasi gitu. Waktu dulu melahirkan, ibu normal, ibu melahirkan biasa, atau operasi. Kalau dokter kan 1, 2 dari kanan ke kiri, kalau operasi 3 dari bahu ke sini, operasi gitu. Dulu melahirkan normal atau biasa, atau operasi gitu. Kalau sesar mungkin tunarungu nggak akan paham ya sesar itu apa gitu. Kemudian siapa yang dulu dokter yang membantu kelahiran anak pertamanya misalnya gitu. Siapa nama dokter dulu yang melahirkan anak pertama atau anak kedua, anak ketiga gitu. Misalnya gitu. Siapa nama dokter yang bantu kamu lahir anak pertama gitu. Kemudian kalau misalnya saya dulu operasi karena di dalam perut saya air sudah pecah atau ketuban pecah gitu ya. Air pecah, jadi harus lari ke rumah sakit dan harus operasi, melahirkan operasi, misalnya gitu jawabannya. Kenapa dulu operasi? Misalnya, karena saya lama, nunggu lama, terlalu lama. Saya juga tidak paham ya kenapa sebab-sebabnya operasi ini. Jadi mungkin yang lebih paham Bapak Ibu. Jadi mungkin bisa dulu kenapa kamu operasi, atau misal jawabannya seperti ini. Saya dulu operasi karena saya makan pedas. Jadi perut sakit, lalu periksa ke rumah sakit dan suruh melahirkan operasi, misalnya jawabannya gitu. Atau mungkin saya sudah tidak kuat karena saya pusing atau karena saya lemas, karena saya pusing atau saya lemas, jadi saya minta operasi, misalnya gitu. Terus waktu ibu menyusui apa pernah demam, kemudian perdarahan dan kejang, atau anaknya seperti itu, atau bagaimana gitu. Jadi bisa, pokoknya kita bicaranya secara singkat. Jadi bisa dengan dulu waktu bayi pertama, misalnya bayi pertama menyusu, kalau ini bayi, kalau menyusu lebih ditekankan ke dada. Bayi menyusu, apa pernah demam, keluar darah seperti men dan kejang, misalnya gitu. Atau kita bisa tanyakan satu-satu. Dulu waktu bayi menyusu, apa pernah demam, misalnya gitu. Oh, nggak pernah. Terus keluar darah seperti men, misalnya. Oh, nggak pernah. Atau kejang, nggak pernah gitu. Jadi kita bisa bertanya dengan satu poin gitu. Kemudian menanyakan riwayat keluarga berencana. Jadi kita bisa menanyakan ini kehamilan yang ditunda atau yang disengaja, mungkin seperti itu. Bisa kita dengan isyaratkan dulu waktu belum hamil pernah tunda, tidak ingin punya anak. Dulu waktu belum hamil pernah tunda, tidak punya anak. Bisa seperti itu. Terus mungkin ini alat apa untuk tidak hamil, ini bisa, kalau ibu normal mungkin ibu pernah menggunakan alat atau suntik KB atau alat untuk menunda kehamilan gitu. Kalau tunarungu ini alat tunda kehamilan itu seperti apa, KB itu seperti apa, mereka nggak akan paham. Jadi bisa kita gunakan alat apa untuk ibu agar tidak hamil, misalnya gitu. Jadi bisa alat apa untuk ibu tidak hamil. Jadi bisa kita sederhanakan bahasanya ke bahasa yang bisa dimengerti. Kemudian menanyakan riwayat kesehatan ibu. Di sini nanti kan kita kalau kita misalnya ditanya, apakah ibu punya penyakit jantung, hepatitis, diabetes, asma, infeksi menular seksual, HIV, dan epilepsi, misalnya gitu. Kalau itu kita bisa menuliskan, kemudian tunarungu nanti kita berikan, kemudian tunarungunya akan mencontreng, menyawang gitu, menyawang misalnya, saya tidak pernah sakit jantung, tidak pernah ini, tidak pernah ini, tidak pernah ini. Apakah ibu yakin misalnya gitu? Ibu yakin tidak pernah ini? Iya, saya yakin. Sudah pernah tes ini misalnya? Belum. Nanti kan akan diarahkan untuk tes. Kemudian menanyakan riwayat kesehatan keluarga. Jadi misalnya keluarga ada yang anaknya kembar atau sekarang tinggal sama siapa, terus misalnya dengan ibu, bapak, om, tante, ini misalnya gitu. Terus apakah di rumah ada yang sakit, misalnya seperti itu. Ya, ibu saya sakit tapi sudah lama misalnya gitu, atau sakit apa, kan kita bisa tanya apakah itu sakit menular atau bukan sakit menular, seperti itu. Next. Terus menanyakan pola pemenuhan kebutuhan nutrisinya ibu ya, misalnya makan satu hari berapa kali, misalnya 3 kali, terus makan banyak atau sedikit, terus biasanya makan apa, ada sayur, misalnya ada di sini ada sayur, makan nasi, lalu sayur, ikan, ayam, misalnya gitu. Kemudian satu hari minum berapa gelas, satu hari minum berapa gelas. Kemudian minum misalnya minum 6 gelas. Biasanya minum apa? Misalnya kalau pagi saya minum teh, atau kalau malam saya biasanya minum kopi gitu. Terus aktivitas apa saja yang digunakan, eliminasi misalnya pipis berapa kali, BAB berapa kali. Kalau ini tunarungu, kalau BAK dan BAB itu kesulitan ya. Kalau tunarungu itu BAB ya pergi ke toilet, kalau BAK pergi ke WC, walaupun itu sama. Misalnya sama-sama di toilet yang sama atau sama-sama di tempat yang sama. Kalau misalnya pipis itu pergi ke toilet, kalau BAK itu pergi ke WC, biasanya gitu. Misalnya kita tanya, ibu pergi ke toilet berapa kali, atau ibu pergi ke WC berapa kali, misalnya gitu. Ketika ke toilet, ibu sakit atau tidak, atau ketika ke WC ibu sakit atau tidak. Kemudian aktivitasnya, aktivitas apa yang biasa ibu lakukan, misalnya saya kerja di pabrik, atau saya kerja ini, kerja itu, biasanya kan gitu. Kalau ibu kerja, biasanya ibu istirahat, ngapain, apa yang ibu lakukan ketika istirahat, maksudnya seperti itu pertanyaannya ya. Kalau istirahat, biasanya ibu ngapain tuh. Atau kalau misalnya saya biasanya duduk, atau saya biasanya makan kalau istirahat di kerja gitu. Terus kalau istirahat di rumah, misalnya kalau istirahat biasanya apa, kalau di rumah. Oh, saya kalau sudah pulang kerja saya biasanya tidur gitu, atau saya biasanya apa gitu, saya kalau istirahat di rumah saya tidur tapi cuma sebentar misalnya gitu. Terus kita tanya, satu hari tidur berapa lama atau berapa jam gitu. Misalnya saya tidur dari jam 7 sampai jam 6 gitu. Nanti mereka akan menjelaskannya. Terus seksual 1 minggu berapa kali hubungan suami istri, terus apakah yang dirasakan, biasanya kan gitu. Jadi kalau gini, kalau tunarungu 1 minggu berapa kali hubungan suami istri itu tunarungu enggak paham ya. Jadi kalau yang saya tangkap selama ini, kalau hubungan suami istri itu mereka menyebutnya ML. Jadi 1 minggu berapa kali ML tuh, misalnya seperti itu. Kemudian menanyakan riwayat psikologi dan sosialnya, misalnya psikologi, sekarang ibu takut apa yang ibu takutkan dalam kehamilan ini, misalnya seperti itu ya kalau kita di orang normal. Kalau orang tunarungu kita bisa gunakan sekarang ibu takut apa, misalnya dia bingung takut apa, takut dalam kehamilan ini. Oh, saya takut bayinya hilang atau keguguran, biasanya seperti itu. Atau saya takut saya tidak bisa jaga bayi ini. Saya takut saya tidak bisa jaga bayi ini, misalnya gitu. Kemudian sosialnya, bagaimana keluarga dengan kabar ibu, apakah senang ataukah sedih. Terus kalau di rumah siapa yang bantu ibu bersih-bersih, rencana melahirkan di mana, dokter siapa, dan sebagainya. Nanti itu kan ada di panduan KIA ya sepertinya. Jadi bagaimana keluarga dengar kabar ibu hamil. Kalau di rumah siapa yang bantu ibu untuk beres-beres, rencana melahirkan di mana, dan dokter siapa, seperti itu. Next. Next ya, terima kasih. Mungkin itu yang bisa saya sampaikan dalam kesempatan kali ini. Selanjutnya saya kembalikan ke moderator.
Baik, terima kasih atas materi yang telah disampaikan oleh Ibu Firly, yang sangat menarik bagi mahasiswa calon tenaga kesehatan yang ingin belajar mengenai bahasa isyarat, sehingga dapat bermanfaat apabila kita diharuskan memberikan asuhan kebidanan bagi ibu berkebutuhan khusus. Nah, karena penyampaian materi oleh narasumber ketiga kita telah disampaikan, maka kita akan beralih ke sesi selanjutnya, yaitu sesi diskusi atau tanya-jawab. Kepada para peserta yang sudah bertanya, saya akan memilih secara acak. Pertanyaan yang pertama ada dari Aisyah Dia dari P3 Kebidanan Malang. Saya akan bacakan pertanyaannya. Apabila bertemu dengan seorang ibu yang berkebutuhan khusus sedang berbicara bersama kita yang sebagai bidan, namun bidannya ini masih kesulitan dalam menggunakan bahasa isyarat. Nah, karena pengetahuan dasar si bidan ini dalam bahasa isyarat masih kurang. Nah, ini juga nyambung dengan pertanyaan selanjutnya dari Lavivatus Profesi untuk pengajar kebidanan. Jika ibu hamil tidak bisa bahasa isyarat, penekanan bahasa pada apa untuk memudahkan komunikasi. Jadi yang pertama tadi bidannya yang belum bisa bahasa isyarat, lalu yang ini adalah ibu hamilnya yang tidak bisa bahasa isyarat. Seperti itu. Mohon untuk dijawab, Ibu Firly.
Ya, baik, terima kasih ya, pertanyaannya sangat menarik. Yang satu bidannya nggak bisa bahasa isyarat, yang satunya yang tunarungunya yang nggak bisa bahasa isyarat. Jadi yang pertama yang saya jawab adalah yang bidan dulu ya. Yang bidan dulu, memang ya kita nggak semua nggak semua harus kita kuasai gitu, nggak semua bahasa isyarat semua itu kita kuasai. Jadi kita bisa menekankan pada satu titik, misalnya kita nggak bisa bahasa isyarat, kita bisa menggunakan bahasa oral yang tadi, atau bahasa yang gerakan bibir, kemudian kita bisa berbicara dengan melihat matanya, melihat kekhawatirannya. Misalkan kan kita bisa melihat ya, misalnya saya hamil tapi saya nggak tahu ini hamil berapa bulan misalnya gitu kan. Jadi kita bisa melihat secara misalnya ini tunarungunya, ini bidannya, kita bisa berhadapan-hadapan, kita bisa melakukan kontak mata sehingga tunarungu juga akan melihat ekspresi wajah kita, gerakan bibir kita, seperti itu. Kemudian yang untuk tunarungu yang tidak bisa bahasa isyarat, padahal misalnya kita sudah belajar bahasa isyarat, tapi kita menemui pasien tunarungu, tapi kok dia tidak bisa bahasa isyarat ya, atau dia misalnya isyaratnya beda ya dengan kita ya, dengan yang kita pelajari ya, gitu. Misalnya seperti itu. Memang bahasa isyarat di Indonesia ya, terutama itu banyak. Ada SIBI, ada Bisindo, dan semua isyarat di Indonesia ini juga berbeda-beda. Misalnya di Malang sama di Surabaya pun itu isyaratnya beda. Maksudnya misalnya kata ini di Malang isyaratnya seperti ini, tapi kok di Surabaya isyaratnya seperti ini ya, gitu. Tapi itu bisa kita tekankan pada kata kuncinya. Misalnya ibu periksa kehamilan ibu sakit apa, misalnya keluhannya apa gitu, itu bisa kita tekankan pada poin utamanya atau pada kata kuncinya itu. Misalnya seperti itu. Itu mungkin jawaban saya. Apakah ada yang bertanya lagi atau menyanggah jawabannya?
Baik, terima kasih atas jawabannya, Ibu Firly. Langsung ke pertanyaan selanjutnya saja, deh. Selanjutnya, ini 2 pertanyaan yang menyambung juga, akan saya jadikan satu saja. Dari Asa Aprin Tania, profesi bidan. Permisi Ibu, izin menanyakan, apakah harus melepas masker terlebih dahulu agar komunikasi dengan tunarungu memahami secara oral, atau dengan cukup dengan isyarat tangan sudah dapat dimengerti? Ini juga nyambung dengan pertanyaan dari Ibu Yuniase dari Prodi Kebidanan Jember. Bagaimana cara menghindari miskomunikasi pada pasien dengan pasien yang berkebutuhan khusus?
Terima kasih ya, ini juga sangat menarik ya. Jadi kalau kita berkomunikasi dengan teman-teman kita yang tuli atau teman-teman kita yang tunarungu, sebaiknya memang kita lepas maskernya ini. Tapi kalau kita sudah menguasai bahasa isyarat dan isyarat kita sama isyarat yang tunarungu itu nyambung, kita tidak perlu melepas masker pun juga sudah bisa sebenarnya. Tapi kalau lebih baik memang dilepas maskernya agar gerakan wajah kita sama kontak mata, kemudian bahasa oral kita itu juga bisa dilihat dengan jelas oleh si tunarungu ini. Kemudian bagaimana cara menghindari miskomunikasi pada pasien yang berkebutuhan khusus. Jadi bisa dilakukan miskomunikasi ini memang sangat banyak ya kalau tunarungu ya. Kadang kita sudah menekankan kata kuncinya, kita sudah menanyakan berulang-ulang, kita sudah mengingatkan berulang kali. Tapi kadang tunarungu beranggapan seperti apa ya? Seperti kayak, oh ini bukan ini, misalnya. Itu terjadi, bisa jadi ya, miskomunikasi ini bisa jadi karena pertanyaan kita yang kita ajukan ke tunarungu itu sangat banyak, sangat panjang, sangat detail gitu. Jadi tunarungu bingung, kata kuncinya ini apa ya? Misalnya kita tanya gini, ini Bu, ini bukunya tidak boleh hilang ya, ini sampai 5 tahun anaknya, ini buku KIA-nya harus disimpan gini. Itu kadang kan kita nggak sadar ya, kita berbicaranya sudah panjang seperti ini, berharap bahwa si tunarungu ini mengerti, tapi malah tunarungu malah, loh Bu, bukunya mana? Loh, itu nggak bilang kalau bukunya harus dibawa atau apa gitu. Jadi kita bisa menekankannya dengan dengan apa ya? Ini dengan bicaranya tidak berbelit-belit. Jadi pendek-pendek saja. Misalnya buku ini harus dibawa setiap kali periksa, misalnya gitu. Atau buku ini disimpan sampai anak umur 5 tahun gitu. Jadi pendek-pendek, yang penting mereka mengerti gitu. Jadi bahasanya tunarungu memang ya, bahasa dewasanya tunarungu setara dengan bahasa anak SD kelas 3. Jadi bisa kita pendekkan pertanyaannya atau kita pendekkan kalimatnya sehingga sehingga tunarungu itu akan paham. Seperti itu. Terima kasih.
Baik, selanjutnya adalah pertanyaan yang terakhir dari Desi Aprilia dari D3 Kebidanan Malang 3B. Seperti yang sudah dijelaskan tadi bahwa gerakan dalam bahasa isyarat itu kan sangat banyak. Nah, lalu apakah ada tips atau trik tertentu untuk pemula sehingga kami lebih mudah dalam menghafal bahasa isyarat tersebut?
Ya, baik. Kalau saya bilangnya itu bahasa isyarat memang banyak ya, memang banyak. Saya kamusnya itu beda-beda, ada yang kamus dasar, ada kamus menengah, kamus ini, terus bahasa dalam bahasa pemerintahan, bahasa dalam ilmu kedokteran, bahasa dalam itu semuanya banyak memang kamusnya itu. Tapi kita bisa dengan cara apa sih kita, atau belajar apa yang pertama kita lakukan agar kita mengetahui bahasa isyarat gitu. Kita bisa belajar dulu abjad, angka, kata tanya, kata tanya, pokoknya seperti kita belajar bahasa Indonesia ketika kita masih SD. Kan kita kan pertamanya kan diajari abjad, angka, kemudian kata tanya, kemudian nanti mungkin kalimat, terus kata perintah, seperti itu. Jadi kita memang harus step by step, jadi nggak bisa kalau kita, meskipun misalnya ya ada teman yang tunarungu, terus kita gandeng aja tunarungu dan kita berharap kita bisa dalam bahasanya itu, kan bahasa dalam bahasa Indonesia atau bahasa kita saja kan itu kan banyak ya, jadi nggak mungkin kita juga bisa mengetahui bahasa isyarat yang banyak itu kita serap dalam waktu 1 minggu, 1 bulan, atau satu tahun bahkan. Jadi kita harus belajarnya step by step. Misalnya kita bisa dengan abjad dulu, menghafal abjad. Kalau sudah abjad, kemudian kita hafal angka, kemudian kita hafal kalimatannya, kita hafal nama-nama bulan, nama-nama hari. Terus bagaimana kalau angka 1 sampai 10, 10 sampai 11, puluhan, ratusan, ribuan, jutaan, itu kan isyaratnya memang berbeda-beda. Seperti itu.
Baik, terima kasih Bu atas jawaban yang dari teman-teman. Terima kasih atas jawabannya. Baik, sesi pemaparan materi dan diskusi telah selesai. Saya ucapkan terima kasih kepada para peserta yang telah berpartisipasi dan mengajukan pertanyaan. Juga kepada Ibu Firly yang telah membagikan ilmu kepada kami. Nah, berikut saya akan membacakan kesimpulan dari materi narasumber kita yang ketiga, yaitu cara berkomunikasi dengan tunarungu itu harus jelas, sederhana, dan volume suara itu tidak perlu dibesarkan. Lalu, untuk teman-teman yang ingin belajar, yang tadi sudah dijelaskan oleh Ibu Firly, dapat menonton ulang live streaming ini di YouTube Jurusan Kebidanan Poltekkes. Semoga ilmu yang kita peroleh hari ini bermanfaat. Mohon maaf apabila ada kesalahan kata dari saya. Dan untuk waktunya saya serahkan kembali kepada MC Kak Radinta Jasmine.
Thank you to Anissa Sunibju. All knowledge has been transferred to our mind and all questions have answers. May this discussion take us one step closer to improving maternal and child health by enhancing equal rights for women. Dear participants, apparently the evaluation from was shared via chat box. We'll remind you once more to fill the form correctly and will be closed at the end of the event. The next event was a thank you from the head of the Midwifery Department of the Health Polytechnic of the Ministry of Health Malang, which will be conveyed by Mrs. Herawati Mansur SST MPD Embassy. To Mrs. Herawati Mansur SST MPD Embassy, time and place were welcome.
Thank you, Mbak Dinta. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Mohon maaf ya, Bu Era nyambut pakai bahasa Indonesia aja ya. I deliver my closing statement for in Indonesian. This is Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk kita semua. Yang saya hormati Bapak Direktur Poltekkes Kemenkes Malang, Bapak Satya Kemenkes. Yang saya hormati para narasumber, Mrs. Shirley dan Mrs. Maria Sama, ya, Mariamah, dan yang saya hormati Bapak Kisa Bahari selaku Koordinator Hubungan Internasional. Yang saya hormati seluruh para kaprodi Kebidanan di Jurusan Kebidanan Poltekkes Malang, dan yang saya sayangi seluruh mahasiswa, seluruh panitia, dan peserta kuliah tamu pada siang hari ini dan para undangan yang ikut dalam kegiatan kuliah tamu pada siang hari ini. Marilah kita panjatkan puji syukur kehadirat Allah Subhanahu wa Ta'ala yang telah memberikan kita kesehatan, yang merupakan harta yang paling berharga, serta waktu dan tempat untuk bertemu dengan dalam kesempatan ini, sehingga bisa berkumpul untuk mentransfer atau mendapatkan pengetahuan dari pembicara yang luar biasa ini. Syukur Alhamdulillah Rabbil Alamin, kuliah tamu telah dilaksanakan dengan baik pada siang hari ini, mulai pagi tadi, pukul 8 hingga hampir jam 1 ya, jam 13.00. Oleh karena itu saya ingin mengucapkan banyak terima kasih kepada pembicara yang luar biasa untuk materi yang sangat berharga, yaitu Mr. Mariamah Masalamani dan Mr. Ibu Maria Geril Jordan dan Ibu Firly Imaniar, dan yang tidak kalah penting selamat untuk panitia dan semua yang sudah membantu atau mensukseskan acara kegiatan pada hari ini. Mudah-mudahan kami masih bisa melanjutkan kegiatan seperti ini lagi dan melanjutkan kegiatan kepada kegiatan yang lainnya, misalnya pertukaran pelajar, kemudian penelitian dan pengabdian kepada masyarakat seperti yang sudah disampaikan oleh Bapak Direktur pada saat memberikan sambutan tadi. Terima kasih atas keseruan diskusinya, mungkin panitia ya di dalam mempersiapkan ini diskusi sampai malam atau berhari-hari gitu ya, sehingga baik itu mahasiswa Poltekkes Kemenkes Malang khususnya jurusan Kebidanan, dan mahasiswa Maksa University Malaysia dan mahasiswa San Paulo University Filipina. Semoga segala ide dan ilmu yang telah kita serap menjadi berkah untuk kedepannya dan membawa manfaat pragmatis bagi kita semua. Saya atas nama Jurusan Kebidanan Politeknik Kesehatan Kemenkes Malang, mewakili panitia acara juga meminta maaf jika ada kekurangan atau miskomunikasi dari penyelenggaraan acara ini. Mudah-mudahan kedepannya ada kemajuan untuk menjadi lebih baik. Dan sekali lagi saya ucapkan banyak terima kasih kepada narasumber dan kepada para kaprodi, para undangan, serta pada seluruh hadirin yang sudah berpartisipasi pada kegiatan hari ini dan sudah meluangkan waktunya. Itu yang mungkin yang bisa saya katakan dan saya ucapkan, dan itu masih belum cukup untuk mengungkapkan rasa terima kasih kami. Saya berharap kita semua selalu dalam keadaan sehat dan sampai jumpa di kuliah tamu atau kegiatan berikutnya. Akhirul kata, wassalamualaikum warahmatullahi wabarakatuh.
Thank you to Mrs. Herawati Mansur, SST MPD Embassy, for giving thanks and closing this morning event, Kuliah Tamu, 25th of September 2021. Eventually, we've come to the end of the event. Before we end the event this morning, please prepare your sweet smile and turn your camera on because we will do photo session together. Once again, please prepare your sweet smile and turn your camera on because we will do a photo session together. Photo session started. For first slide, I will count 1, 2, 3. For second slide, I will count 1, 2, 3. For third slide, I will count 1, 2, 3. Next slide, I will count 1, 2, 3. For next slide, I will count 1, 2, 3. For next slide, I will count 1, 2, 3. Photo session finished. Well, I'm here as the host and as a representative of all parties who participated in the success of this event. I apologize profusely if in the implementation of this webinar there are still many mistakes and shortcomings, as well as express gratitude to the speakers, the lecturers, and friends of students, the committee, and the entire audience. Hopefully, what we get today can be useful for all of us. Thank you for your presence and participation. See you at the next guest lecture event. Finally, wassalamualaikum warahmatullahi wabarakatuh. Don't forget to participate to fill the presence form to prove your attendance, but no need to fill it twice. Thank you.
Kenapa?
Kan ini stempel merah prioritas katanya.
Oh, kenapa maksudnya? Adik-adik panitia bisa minta tolong peserta yang masih ada mungkin bisa dibantu remove ya. Kita evaluasi sekalian ya sebentar ya. Ibu-ibu kaprodi yang lain mungkin masih ada di Zoom.